Good evening once again, and welcome to day 4 of Oncology Pharmacy Conclave 2025. We begin today with one of the most promising frontiers in cancer care, precision medicine. We begin today. It's my honor to introduce Dr. Srinivasa Tejaswini, a respected professional specializing in pharmacogenomics and individualized therapy. She is distinguished medical oncologist. She is a distinguished medical oncologist, hematologist, and BMT physician at Mala Reddy Cancer Hospital and Research Institute, specializing in translation cancer research and precision oncology. As co founder and director of Cancer Conscious Clinic, Fifth Care Solution, and Medic AI, Dr. Tejaswini leads groundbreaking innovation in AI driven oncology solutions, developing digital health platforms that enhance therapeutic outcomes and advance personalized medicine approaches. She brings unique expertise spanning clinical oncology, healthcare innovation, and strategic research leadership. Her multidisciplinary approach encompasses is clinical trial supervision, biomarker research, and next generation therapeutic interventions. Her current focus integrates precision oncology, immunotherapy innovations, and AI enhanced diagnostic platform to revolutionize cancer treatment paradigms, positioning her as a leader in technology driven, evidence based cancer care that aims to improve global patient outcome through cutting edge research and clinical excellence. Before we begin, I would like to inform you all that we'll have a Q&A session after this talk, so please keep your questions ready. She will be speaking on precision medicine in action, pharmacogenomics for personalized cancer care. Ma'am, the stage is yours.
Okay. Yeah. Is it visible?
Yes, ma'am, it's visible.
Yeah. So we'll start a topic today. So today I would like to discuss regarding precision medicine in cancer because we are hearing a lot regarding precision medicine, personalized care a lot. So I want to explain regarding that in oncology. So precision medicine in action, mainly the pharmacogenomics for personalized cancer care. So pharmacogenomic is something the drugs, its effects, and its toxicity compare when it comes to the genome and regarding the cancer genes too. So, firstly, what is precision medicine? So, precision medicine is tailoring the medical treatment to individual characters of each patient. The goal is to deliver the right drug at the right dose to the right patient at the right time. So, this is what precision medicine. So, how do we get through precision medicine for each individual? It's like a personalized treatment. So coming to pharmacogenomics. So what is pharmacogenomics? I think most of you are pharm students, so you will be knowing regarding pharmacogenomics. It is a field which is concerned with impact of genetic changes which determine individuals' response to specific drugs. So what medications they generally help evaluate the pharmacogenomics are normally the blood thinners, mood stabilizers, anesthesia drugs, antibiotics, pain medicines, and cannabis. Apart from these, the chemotherapy drugs. I'm going to concentrate mostly on chemotherapy because it is something related to onco and pharmacogenomics. So, the role of pharmacogenomics is the study of the genome towards the drug response and combining pharmacology and genomics. So, it analyzes how the genetic makeup of every patient affects their response to drugs. So, it predicts the efficacy and toxicity and guides personalized. And coming to pharmacogenomics in oncology. Hello, am
Ma'am,
I
your
audible?
voice is not clear.
Am I audible?
Yes, ma'am,
Yes,
you're
ma'am, you're
audible.
audible.
Yeah, yeah. So the pharmacogenomics in oncology. So cancer therapy from the empirical chemotherapy, now it has come towards the personalized medicine that is the targeted and immunotherapies. So using individual genetic profiles, both of the tumor as well as the patient's blood sample, that is the inherited one, to personalize cancer treatments, predicting the effectiveness of drugs and the toxicity for better outcomes. So this is what is pharmacogenomics in oncology. So in cancer pharmacogenomics, how a therapeutic drug able to take the drug or not, or to adjust the dose. So firstly, we'll go with the tumor genome, and we will be checking the efficacy of the treatment which is given, that is tumor sensitivity, variation of the treatment outcomes, pharmacokinetics, that is toxicity of treatment, germline genome also. So there are two things before a therapeutic drug is being made. One is testing the tumor genome, and other one is germline genome. So tumor genome, the sensitivity of the tumor to that, and germline genome for the pharmacokinetics, how the drug behaves in that particular individual. So variation of both the treatment outcomes together gives us the main thing that how this drug is going to affect this particular patient for this particular cancer. So there are two things. One is the host genome that is taken from the blood sample, and it is the inherited one. Other one is the tumor genome. So host genome, it gives us the systemic pharmacokinetics of the body, drug toxicity, whereas the tumor genome gives us the cellular pharmacodynamics, cellular pharmacokinetics, the drug sensitivity, that is the tumor. Whereas here what we study are the DNA and RNA. DNA as the canvas genes, whole genome sequencing, and the epigenetics. In the RNA, we see the mRNA, microRNAs, and transcriptome sequencing. So finally, the clinical treatment outcome, what we see will be the event-free survival, toxicity risk, overall survival, and target inhibition. There are at least two genome of importance. One is the patient's germline genome, which is the inherited one, and the tumor genome, which is inherited genome plus acquired genomic variation. So there may be additional acquired genome variations also in some kind of cancers like metastatic or stage 4 cancers or recurrent tumor cells, which influence the drug response and also the treatment outcome. So overall, a comprehensive pharmacogenomic strategy, it helps us in interrogating all the multiple mechanisms of genome variations, both the germline and the tumor genetic material, and then influences the multiple drug response phenotypes. That is the genome-wide associated studies. So this is what is pharmacogenomics. In cancer patients, what do we do for assessing the pharmacogenomic status? One is firstly the chemotherapy drug, whatever is being given. So we consider all these things like height and weight, that is the BMI, BSA of the patient, sex, age, disease, and organ function, physiology, environment, and all the genetic variations. So all these drugs in the variations in drug response are being checked. So drug toxicity and beneficials or benefits of the drugs. So drug non-toxic and non-beneficial, or drug is toxic and non-beneficial. So we categorize into these three patterns. Then coming to the clinical applications. So where all we will be using this pharmacogenomics. One examples are targeted therapy. The example is EGFR mutation non-small cell lung cancer, where we give erlotinib and osimertinib. They both are targeted therapy against the EGFR mutations. In the same way, immunotherapies, PD-L1 and MSA status, it predicts the checkpoint inhibitor treatment responses. And in chemotherapy dosing, one is regarding the TMPT variation affecting the 6-mercaptopurine dosing, and DYPD mutation and 5FU and capacitabine, that is fluoropyrimidine effect. So we will come to a case study example. One is a 56-year-old male with metastatic colorectal adenocarcinoma. They presented with first-line systemic chemotherapy. Patient was planned for FOLFIRI regimen. After the first cycle, he developed grade 4 neutropenia and diarrhea, despite giving the standard supportive care, and his prior blood counts, liver function, everything were normal, and there is no drug interaction. Usually, with first cycle itself, this kind of severe side effects are very rare. So, what would have happened? To know that, we have done a pharmacogenomic study. In that, unexpected severe toxicity was due to UGT1A1 polymorphism, which is responsible for glucuronidation of the SN38, which is an active metabolite for irinotecan. So, coming to the, so what we have done over here is, after knowing the cause, we have decreased the dose. So now I would like to explain how does this pharmacogenomics act. So when we give a conventional therapy, same dosage for everyone, that is most penetrant genes. So most penetrant genes polymorphism determines the drug exposure in gene A. So there are two genes, gene A and gene B. So gene A will be masking the gene B in conventional therapy. So the concept is in conventional therapy, all patients receive the same drug dosage. So drug exposure, that is the amount of drug in the body, it will vary due to genetic differences. So specific variations in gene A. So when we see the conventional therapy, so gene A effect, some patients have the wild type form of gene A, which causes the normal metabolism. Some have heterozygous, that is the intermediate metabolism, and some have a homozygous variant, which is the poor metabolism. Because of poor metabolism, the toxicity of the drug is highest in homozygous variant. So the result is the same dose will lead to different levels of drug exposure. So in the wild type, normal exposure, whereas in the intermediate type, there is higher exposure. Whereas in one second. Yeah, whereas in very high exposure, so whereas in very high exposure, consequently toxicity will increase and it increases the exposure as shown in this kind of graph over here. So overall, no effect by gene B and exposure dominated is totally by gene A. The effect of gene B is masked here. Whereas in individualized therapy, so when we come to the individualized therapy, the dosage based on most penetrant gene polymorphism, that is the gene A. So number of patients and drug exposure for gene A, that is here the concept is adjusted based on the pharmacogenomic information which is present. So primarily the dominant gene A, based on this, the patients with variant genotypes, that is, so the pharmacogenomic information, mainly the dominant gene, that is for gene A, that is both the intermediate type, that is the heterozygous, as well as the homozygous variants, both the dose is reduced, because of which we can see the toxicity is almost equal in all the three subtypes, that is a wild subtype, intermediate subtype, as well as the homozygous subtype. And here, because of the gene A, the drug exposure being reduced or being masked, being unmasked here. So we can see because of unmasking of gene B, the account of gene B's simpler effects can now become clinically significant. So genetic polymorphism in gene B may explain the residual variation in response to toxicity. So here I will explain with an example here. So here an example as we have seen earlier regarding TPMP, that is thiopurine S methyl transferase and ITPA. Suppose example we can take gene A as TMPT, that is tripurine S methyl transferase, and gene as ITPA, that is inosine triphosphate pyrophosphatase. It will greatly reduce the toxicity. And once PT dose is optimized, then comes the ITPA variant. Hello, am I audible?
Yes, ma'am,
Hello,
you're audible, but your voice is little breaking.
yeah, I'm audible. Yeah. Okay. Now, is
Not
it
clear,
audible now?
but no, ma'am, it's not clear,
Just
a little bit breaking.
yeah, 1 second. Okay. Is it audible now?
Yes, ma'am, it's audible.
Yeah. So once TMPT dosing is optimized here in gene A. So now for gene B, the ITPA variant may further explain the small differences. We can see here the wild type, the number of patients and drug exposure is more compared to the intermediate type and the heterozygous and homozygous variants. So after adjusting the dosage based on gene A, so gene B will influence the drug exposure. So that can also be known. So the masked gene type, that is the ITPA, that also can be known if we unmask the TMP. So this is one of the advantage of giving an individualized therapy or precision therapy. So coming to the next, that is challenges in implementation. So what are the various challenges which we see in implementation? One is the high cost of the genomic testing. Now the genomic testing is still at a higher cost, but gradually it will come down as there will be more and more of new variants and more of the competition being reduced, and limited access in low resource settings, and clinician to be educated. So every pharmacogenomic person has to educate the clinician, and ethical and data privacy issues are one other challenge, because we have to know each and every blood sample and each and every tumor sample of the patient, which is a very big challenge for ethical and data privacy issues. So the data can be misutilized also. So these are the challenges. When these challenges could be addressed, pharmacogenomic study or personalized medicine in cancer would be much full blown. So future directions is the AI-driven genomic analysis, integration of multiomics data, and pharmacogenomic guided drug development. These are the next future generation in pharmacogenomics. So coming to the global Indian perspective, global progress is for the cancer, there is a TCGA as the Cancer Genome Atlas. It's a large scale initiative where all the cancer genes all over the data is compiled and it is put into the global data. And in India, there is pharmacogenomics labs emerging and cost effective NGS platforms are emerging. And there is national genome programs also, like the TCGA itself for India. And concluding our topic, so pharmacogenomics, it bridges the genomics and oncology to personalized therapy, and it enhances the efficacy, decreases the toxicity, improves the quality of life. So the call for action today is integrating the pharmacogenomics into standard cancer care protocols. This can be mostly done when we combine pharma and the medical together, like the oncologist and the pharmacologist or the pharmacy together. Then it will help us in integrating the pharmacogenomics as a standard care protocol, so that we can give the patient personalized care or personalized cancer therapy for each and every individual genetic profile. So these are all the references, and I could acknowledge the oncology teams, patients, and collaborators for this. Thank you. Any questions I would like to answer?
Guys, please to ask questions, anything that is related to pharmacogenomics. If no questions, ma'am, I think there is one question
Any questions
in the chat box.
in the chat box? Okay, I'll see.
Ma'am, would I read it for you? The questions from the chat
Yeah,
box?
sure, definitely. Yeah.
Ma'am, the first question is, what's your view on cyclin D1 and cathepsin D markers in breast cancer patients?
Yeah, they are being studied because, as we know, cyclin D1 and cathepsin D not only for breast cancer, for all the cancers, it's the cell cycle markers. So when cyclin D1 and cathepsin D markers could be studied not only for breast cancer, we can get an indication that there might be any cancerous tissue in the body. So that is one thing, and they cannot be in particular markers only for breast cancer. That I think study is still going on for that. And what is the percentage followed currently for the patients? This I couldn't get the question. Can anyone just repeat the question?
Ma'am, she elaborated the question. Percentage of pharmacogenomics performed in the patient
Okay,
currently, especially
okay.
in India.
Currently, it is very less. I think around 10 to 20% of pharmacogenomic studies are being done, and it is being integrated into the clinical part. So pharmacogenomic studies are going on all over the world, but being integrated into clinical part is quite challenging. So that if it is integrated, then I think it will be fruitful. Yeah, many Indian clinical trials are going on for pharmacogenomic studies. Yeah. And I think how do we implement a healthcare setting pharmacogenomics? Yeah. So I think Pharm D students will be more because they will be knowing both the clinical part as well as the as well as the pharmaco part. So I think pharmacogenomics can be more easily addressed by PharmD students only, and we can implement in healthcare settings. That is, whoever is the PharmD students or PharmD completed like doctors, whoever are there, so they can do they can get this genetic genomic studies done. That is all the data compiling together, so analyzing the data and then forming all the different, like whatever side effects are there. In case if you can first compile the data of what all are the side effects with particular drugs, so based on that we can go and approach pharmacogenomic study labs for getting these studies done. And also I think it's a good opportunity post PharmD also into getting into pharmacogenomics, so it can be a kind of healthcare sector to get into a good job profile. Yeah, I'll share the PPT surely into the group. Yeah, if it's expressed in breast cancer patients, we can give therapies targeting those markers particularly, not only for breast cancer, for any kind of cancers. This pharmacogenomics help in three ways. One way is, as we have discussed, regarding decreasing the drug dosage to reduce the toxicity. Second thing is knowing different, same patient may have two different gene problems. So one gene unmasking will help us find out about the other gene. So that is one another thing. And third thing is, in case if these markers are positive, we can try to do some they can try to do some drug research to get development of newer drugs for any particular targeting any particular markers. This is how that targeted therapy and immunotherapy have been developed. That is because of the pharmacogenomic studies. We could get a lot of targeted immunotherapies right now. How effective is pharmacogenomics, consider the challenges mentioned? Yeah, it is very effective because already we have been using a lot of targeted therapies and immunotherapies. So we ourselves could see the difference between the normal chemotherapies and the targeted immunotherapy. The side effect profile is much more reduced. The patients are confident to take the targeted and immunotherapies. Only some financial constraints are the problem in India. But I think if we can overcome that financial issues, then definitely targeted and immunotherapies will increase the patient lifespan a lot. Because now compared to the chemotherapies, targeted and immunotherapies, they have increased the lifespan by almost 3 to 5 times by now. So pharmacogenomic testing, now it is done. Now what we are doing is, for the patient who are having severe toxicity post chemotherapy, only we are getting pharmacogenomic studies done for them. But later on, if we can get pharmacogenomic studies done for every cancer patient prior to starting therapy, it would be helping much more. So for drug response, we are taking two samples. So for pharmacogenomics, we will be using two samples. One sample is the blood sample of the patient. So that will be helping in knowing the inherited mutations. That is the genetic mutations which are inherited, that is germline mutations. So the other sample which we will be taking is the tumor mutation. In the tumor mutation, we will be knowing mostly along with the germline, we will be knowing the somatic mutations. That is the mutations which have occurred other than the germline mutations. So both the mutations can be studied, both the tumor mutation as well as the patient's germline mutation, so that combinedly we can help in evaluating the drug response. So how the drug response can be evaluated, that I have shown an example earlier. So through that we can know the drug response. Yeah. Yeah, the challenges are a lot, but now after targeted and immunotherapies, lot of challenges could be solved with that. Like with chemotherapies, we have a lot of toxicities. Now we have done lot of things mandatory, like for 5-fluorouracil, as we have told, 5-fluorocapacitabine for the fluoropyrimidines, we are doing a DP-wide mutation testing for most of the patients because now it has come to an affordable range. So that is one change. In the similar way, for few drugs like 6-MP and other drugs, wherever the genetic testing cost is low, we are trying to do one particular gene when we are giving that particular therapy. Instead of that, for all the cancer patients, once they are diagnosed with any particular cancer, if we can get, yeah. NGS is also one of the tool which we can use for pharmacogenomics. So NGS is a method to say it's next generation sequencing, like how we have PCR and how we have fish and other methods like that. NGS is also a particular method. NGS helps in knowing a lot of genes at same time. So studying a lot of genes at same time, NGS helps in that. Instead of doing manual count, instead of personalizing to one particular thing, like how we have PCR, we have one particular gene, or studying very few set of genes together. NGS tells us about the genome, a lot of genes at same time. Liquid biopsy is something which is done through the blood. So liquid biopsy again has multiple things. So once we see in the blood, we see the number of cancer cells and other things. Along with it, another part is we see the circulating tumor cells burden. So this is, and we check the DNA and RNA. Earlier, only DNA levels and of the circulating tumor cells and circulating tumor DNA was studied. That is ctDNA was studied. Now, recently, the liquid biopsy, it has come like all, even the RNA is being studied now in the liquid biopsy. Yeah. Any more questions? Yeah, we can get pharmacogenomic data also from the liquid biopsies. That is only one of the things which we are doing. That is when we are taking the blood sample. ctDNA is being used as a prognostic marker already in most of the cancers. So whenever like it's already being used, but commonly because of the affordability issue, a lot of us won't do it. But in case if patient is affordable and the prognosis of disease is bad or a high risk disease, ctDNA can be used as a prognostic marker. Any questions more? Pharmacogenomic testing the same as regular genetic testing for cancer risk? No, both are different. Regular genetic testing for cancer risk is different. That is, a patient who doesn't have any cancer, we are checking whether any of his genes are very of a higher risk, or can he get any particular cancer in future. But pharmacogenomic testing is completely different. This is already a cancer patient, and how is the treatment going to affect the cancer patient, and what kind of drugs we can give him, what are the newer drugs which we can develop based on his genomic status. For example, I can tell you how we can do a drug discovery through pharmacogenomics. So we can take a particular set of data of patients, and then we can study their genes. So we can compile all the particular similar gene status at one place, analyzing the data as a bunch, and then we can run a pharmacogenomic study on them and try to do a newer drug discovery which is affecting that particular set of genes. In that way, we can do a newer drug discovery which helps in that particular genome. Books, I think there are a lot of books for pharmacogenomics. Instead of that, I think you can go for seeing few papers regarding pharmacogenomics and how it is used in oncology. That will help. Okay, any more questions? Yeah, thank you.
Thank you, ma'am, for accepting our invitation and for the presentation. You have enlightened us with this session. Guys, if you want anything, you can keep questions. The last day of panel discussion also, you will get your doubts cleared. And thank you, ma'am. Thank you for your time.
Thank you so much, Climed, for this wonderful session. Thank you.
Thank you so much, ma'am, for that impactful session. Next, we move to an essential subject for oncology pharmacist and clinician understanding and applying NCCN guidelines in practice. Participants, it's my pleasure to introduce Dr. Ritesh Giri, a PharmD graduate with a specialized residency in oncology from JSS Academy of Higher Education and Research. He brings strong clinical and academic expertise to the field of oncopharmacy. Dr. Giri currently serves as an assistant professor in Department of Pharmacy Practice at Ramaiah University of Applied Science. Prior to this, he worked as a clinical analyst at Navya Care, contributing to evidence based cancer care in collaboration with leading global institute. His research includes publication on PD-L1 expression in lung cancer and molecular pathway in oral squamous cell carcinoma featured in respected oncology journals. He has also undergone an international clinical rotation at the University of North Carolina, USA, gaining exposure across 12 specialties under expert clinical pharmacist. Before we begin, I would like to inform everyone that we'll have a Q&A session after this talk, so please keep your question ready. Please join me in welcoming Dr. Ritesh Giri, who will be presenting Navigating NCCN Guidelines, a step-by-step guide. Sir, we look forward to your guidance.
Guys, from 3 days, right? You've been asking, ma'am, what are these guidelines? From where should we study cancer? How we should study cancer? See, the day has come, and you have Dr. Ritesh here who is having very good expertise in teaching students and mainly this NCCN guidelines. I think all your doubts for 3 days, how to refer guidelines, how do I understand guidelines, how to, ma'am, give me that book, this book. So you'll get all the answers for your question today. And please don't miss out this session. Please take your pens and paper in hand and practice the same when you go back. So you will understand how this cancer is diagnosed, how to diagnose, what is the step by step that you will have to do. Just not seeing the guidelines 300 pages, you get so scared. I think after this session, you will be well versed with this and all your doubts get cleared. Okay, guys, this session would be very interesting, hands on. Please do concentrate throughout the session. You will go out today with like what all you wished for. Okay, guys, please be attentive throughout the session. And thank you, Dr. Ritesh. And to tell, Dr. Ritesh is my friend and classmate, and he's very good in teaching. So please take a chance and opportunity to learn NCCN guidelines today.
Thank you, Dr. Pravalika. I hope I'm audible to everyone. Is my video visible?
Yes, sir, you're audible and visible too.
Yes. And thank you, Ms. Ritul, as well. That was quite an elaborative introduction. So yes, as Dr. Pravalika and as Ms. Ritul have explained, the topic that I'll be discussing for today is on navigating NCCN guidelines, right? So it's been a while since even I have actually accessed these guidelines since I've been previously working in Navya Care, as you just explained. But definitely, we do keep using this quite frequently when we do discuss cancer cases for practical discussions or for case discussions with the PharmD interns. So I'll take you through a bit of the theory aspect of it, probably for the first few minutes, and then we'll take up a small, simple case, which can be easy to follow for the students. And maybe we can take up multiple scenarios in the same case and see how to navigate through the guidelines as well. All right. I'm just going to share my screen. Just give me a few seconds. Is my screen visible to you guys?
Yes, sir, it's visible.
Okay, just give me 1 minute. Okay. So we'll be probably having a little bit of a practical kind of an orientation when it comes to NCCN guidelines because as Dr. Pravalika mentioned as well earlier, guidelines is something that is super important for us, especially when we are deciding certain therapies, the approach towards the therapy, choosing the right regimen for our cancer patients, and that's where guidelines, especially a guideline like your NCCN, will be majorly involved, right? So navigating through it is a little scary at times because initially when we also saw the guidelines for the first time, it was very complex, it was very elaborative, and of course you see a lot of flowcharts, you see a lot of information. So it does get a little overwhelming when you see the guidelines as well, right? But maybe through a little bit of practice and regular use, you can get well versed with it. And when we do this simple case example at the end of this discussion, probably you can understand it a little better. And I'll just take you through a bit of the basics. So I'll keep switching between my windows. Like I'll be going to the website, I'll be going to some of the PDFs. So don't mind if if you're losing me in between here and there, but I'll definitely try to keep the flow going ahead as we discuss the topic, right? So one second. Yes. So just a disclaimer that I'm using this material solely for the educational purpose and definitely not being associated anyhow with NCCN itself, or nor am I endorsing this. And of course, one of the other disclaimers that I would like to give is that most of the clinician-based treatment decisions that most of the oncologists take might vary a bit from the guidelines. But our purpose for today would be just to understand the guidelines a bit more because you might see that sometimes the guideline 90% of the time is definitely followed in the hospital, but some of the variations can come up in the decisions that few oncologists take based on their clinical experience. But whatever we're going to see today is solely based for a educational purpose and to understand how the guideline actually works, right? So what would be the significance of using any sort of a treatment guideline, right? One would be definitely that it gives a practical experience and it is a practical guide for any student or for all the healthcare professionals when you're actually selecting a therapy and you're actually going to implement it. So the practicality plays a major role when it comes to any sort of a treatment guideline. And it definitely does help you standardize the patient care because the kind of therapy that you're going to choose is going to be something that is more standard, more relevant, and definitely more efficacious to your patients. And like I said, a lot of clinicians have a lot of different options that they would prefer going for. But having a guideline would definitely reduce that variability because it will standardize to one single option, or maybe a fewer options which are very easy to choose and it's consistently followed throughout most of the physicians and most of the oncologists when they actually decide the therapy. And definitely, guidelines, especially something like NCCN guidelines, is an evidence-based resource or reference, and it is something that we use to improve the patient outcomes and to make sure that the kind of therapy that we choose is something to have a better outcome for the patient at the end of the day, right? And definitely, given that cancer has multiple regimens and it has a lot of complex and rapidly evolving kind of a background, right? And for any sort of disorders which are constantly developing and rapidly evolving, this guideline or any sort of guideline would definitely help us to streamline the kind of decisions we make when it comes to the therapy. So it kind of gives a very good roadmap when we want to actually choose a specific therapy. And we definitely know that there are a lot of regimens. You would have seen hundreds of regimens when it comes to different cancers. And when it comes to a specific cancer, you see easily 10 to 20 regimens, and you think which is the one that I would actually want to go for, right? So in cancer patients, especially because of the abundance and the diversity of regimens that we have, these kind of guidelines are actually quite vital to help make a proper decision as to what is it that we want to go ahead with, right? So that's where guidelines play a major role. So to be specific about NCCN, just a little bit of history, what exactly NCCN is, right? It's a non-profit US-based alliance, or it's basically a guideline, which is expanded as National Comprehensive Cancer Network. And this was found in the early 1995. So it's going to be close to 30 years now. This is probably the 30th year when NCCN was originated since, right? And initially they started off with just a few cancer centers, just 13 of them. And now they're slowly expanded to almost 33 cancer centers. And you can think of all the top hospitals which are there in the US. If you can think about MD Anderson Cancer Center, if you think about Mayo Clinic, Moffitt Cancer Center, Memorial Sloan Kettering, all the major institutes that you can think of which are there in the US are actually part, and they're actually some of the professionals which are collaborating with NCCN to bring up all these evidence-based kind of information that you get to see in the guidelines, right? And of course, it helps you in formulating evidence-based and a multidisciplinary kind of a recommendation. So the information that you actually utilize for your patients is based on all the research that you get to see around that particular therapy recommendation, and it comes from a diverse background of specialties which is related to oncology, and that's why it's something which is highly rated as a very reliable kind of a recommendation. And definitely, NCCN has become one of the most widely used guidelines among all the oncologists and other healthcare professionals when it comes to treating cancer patients globally in today's world. So when you have a look at NCCN guidelines, I'll definitely take you through the PDF as well, right? But the first thing that you would see is usually when you talk about NCCN guidelines, what are all the cancers that it covers? And it has close to more than 50 cancer types. I would say somewhere around 60, 65 different cancers, which you can see in this particular screenshot that I've taken, right? So all your hematological, all your solid tumors that you can think of, you have guidelines which are well updated. They are most recent and very relevant, which will actually be part of this therapy guidelines. And it's not just only for your chemotherapy related kind of, I mean, not just chemotherapy, it's not just related to any sort of therapy guidelines, but it's also related to your supportive care that you can think of that you need for your patients in terms of pain management, in terms of diarrhea management, or if you can think of chemo-induced nausea, vomiting, right? And general palliative care, survivorship care. These are all some of the things which are actually super vital for your patients as well, apart from the actual cancer therapy. So you have guidelines and you have supporting information for these kind of fields as well when it comes to cancer therapy. And it's not just the therapy aspect again, it's also something to do with your early detection and prevention strategies. So you actually have very well established and you have a very clear-cut information sequence when it comes to what is the way to reduce certain risk. How is it that you can diagnose a particular cancer early? How can you actually undergo surveillance? How can you undergo regular screening? So recommendations based on all of this is also available on your NCCN guidelines, which I'll kind of take you through just superficially once I open the guidelines later on, right? So if anybody has seen NCCN guidelines, if you've ever actually gone into the NCCN guideline, this is how you can see that the structure of an NCCN guideline is, right? Like I said, it's a lot of information, it's a lot of arrow marks, and it's a lot of links that you need to click on, and you're not sure where exactly that you need to start from, right? But when you see a specific structure, there are three things that you need to understand. The first one that you see in the red box over here, you see a lot of different arrow marks and you see a lot of different algorithmic flowcharts, right? So these arrow marks are also called as nodes. And these algorithmic flowcharts are basically giving you a direction or a roadmap as to what is the next decision that you're supposed to take when it comes to choosing a specific type of diagnostic approach or a therapeutic approach. All right. So algorithmic flowcharts, again, I'll tell you a little bit more about it as we go ahead. But that's the first thing that you see when it comes to the structure of an NCCN guidelines. So it's all about your nodes and your arrow marks, which is what you need to understand as to where you need to go next based on your patient's condition. The next thing that you see right below is something we call as footnotes, which is something very important, something that we're not supposed to ignore, because if you can see, again, I'm not sure how visible these points are, but if you can see certain small alphabets on the top, like you see on the workup over here, there's a small A. Then you see at breast MRI, there's a small B over here. Those are basically some of extra insights or extra information that is there available in your footnotes, right? And these footnotes are super important because they also kind of influence the next step that you're going to take. So if you're going to go through the guideline, you have to read the footnote because sometimes the footnote might influence the decision of your therapy or of the kind of diagnostic parameter that you're going to choose. So these are some of the things which are very important to be considered. So apart from your nodes and your arrow marks or whatever you see these flowcharts, equally important, or sometimes I would say more important, are also your footnotes, which has to be considered when it comes to making certain treatment decisions as well. So that's the other part of your guideline. And one more thing, which I'll show you a better image apart from this, but the third part of the structure would be your treatment recommendations, which are nothing but which is the type of treatment that you'll actually go for based on the category of recommendation or the preference that you need in terms of what NCCN tells you as to which is better, which would be the first line, which would be a much better option, right? So you talk about treatment recommendations, you always want to go for something that is highly recommended, which has a high history of evidence, which is something that has been followed in multiple trials and has given you a consistent result in most of your patients. And that's something that you would also want to prefer for your patient, right? And that's exactly what comes under your categories, which we'll see a little bit more in depth. Okay. So, for example, I just put another screenshot just to show you. In this small red box, you have your particular type of a surgical recommendation that is given. You can see that there is a node, right? You can see that there is a particular category that has been written as category 1, which is actually supposed to be a very high evidence. And you can also see small alphabets, which are your footnotes. So I'm just showing you that, in a small image here, we have 3 of the main structures that you're actually getting to see, right? You get to see the algorithmic flowchart, you get to see the footnotes, and you also get to see the treatment recommendation in terms of category, right? So this another image, which I think probably when we discuss the case, we'll be able to see a little bit more better. All right. So we'll get back to this in some time. So the main things which I just spoke about in the structure, right? The algorithmic flowcharts. You have information that is mainly connected by your nodes, by your arrow marks, because this can be a step-by-step kind of a guide for your healthcare professionals. It can be for you students as well when you're actually going through a guideline, because you need to know what is the next thing that you need to choose, right? And that's where algorithmic flowcharts are going to actually be very helpful, because it will kind of tell you the next step. All right. And of course, it gives you a very clear flow and a connection of information. So you can connect information from what you actually decided on step 1. And then when you go to step 2, how does it actually get influenced because of the decision that you took on step 1? So that clear flow and connection follows when you're choosing with the help of all these nodes and arrow marks. All right. And then footnotes, like I said, they're quite important. And why footnotes are super important is because they talk to you about not just choosing which is the best therapy, but sometimes they can also influence the kind of modifications you want to make in the dosage of a particular medication. Sometimes you see certain guidelines apart from NCCN. For example, you have ASCO, which is also another important body when it comes to clinical oncology. You have ESMO, which is a European guideline. And some of the studies and some of the trials which have been discussed in these conferences are also actually being put up in the footnotes, which will also be something that can be utilized as part of making these recommendations for NCCN. So you get those trial evidence summaries as well, or certain trials which have been carried out recently, which will be summarized at the bottom, which will actually be correlating to the data that you're reading in the algorithmic flowchart, right? And of course, you have special population considerations like pregnancy, comorbidities, few of the things, right, which has to be taken into consideration, especially when you're considering things like radiation therapy for pregnant women. That's something which you'll have to be quite careful about. And certain medications which cannot really be considered in certain comorbidities. You take drugs like anti-HAR2 therapies like trastuzumab. Your patient comes to you with a history of heart failure where person has a reduced ejection fraction of less than 50%. You might have to go for probably something a little bit more safer, right? And that's where comorbidities, conditions like pregnancy will definitely help you influence your decision of what is it that you're going to choose next. So that's where footnotes are actually quite important. And of course, in red, I've highlighted this that, do not skip them at all, like I said earlier, because they can change the meaning of your entire pathway and influence the decision that you're going to take next, which is why just going through the flowchart might not be helpful sometimes. You might have to come to the footnotes, or I wouldn't say might, you have to come to the footnotes. You need to see what exactly is being written over there. You need to take that into consideration and then move ahead so that you can take the right decision as you go along the flowchart. All right. So that's something that you need to remember about your footnotes. And when it comes to your third part of the main structure, like I said, your evidences, your consensus, these are something which will actually help you to decide which is the therapy that I actually want to go for. And as you can see, if you see something which is a category 1 kind of a recommendation, these are recommendations which have been published in a lot of trials, in a lot of meta-analysis. This is an information that is available in a lot of studies that has been done. And it's uniform. When I say uniform, it means that whoever is on the NCCN panel, more than 85% of these people will support that data. And that is something which is very appropriate to choose for your patient, right? So category 1 recommendations are always the best and the go-to kind of therapy options that you have. And as the category goes below, you see that the evidence amount kind of lowers, the kind of agreement among the NCCN panel also kind of lowers, right? As it becomes category 2A. Most of the recommendations, if it is not mentioned, then it's always category 2A, like you can see at the bottom over here. If a specific recommendation, if you saw in the previous slide, right, you can see that it is category 1 over here. So you have a category being mentioned. If your category is not mentioned, then this is how they're going to mention it, saying that all the recommendations are category 2A unless and otherwise they are indicated. So technically, if you have information about what category it is, it's usually a category 1 kind of evidence that you would want to go for. But if it is not available, then you automatically consider it to be a category 2A evidence, which has comparatively lower evidence, but the consensus at least is uniform and it is something that has a general agreement when it comes across all the panel members, right? But as it goes below, you see that a lot more disagreement happens and the kind of evidence that is available is quite low. So it's very hard to rely on such data, and it's something which is, uh, not very, well established. So it becomes kind of a clinical judgment at this point where you don't have any other option. Maybe if this is the last resort, then that's the kind of category that you want to go for, but that's not the first thing that you would want to actually put your hands into. So that is where your level of evidence plays a major role, giving more preference to all category 1 kind of recommendations. And the other thing that you also get to see is these words like preferred or others are recommended or some are useful in certain conditions or certain circumstances. These are some words that are also written next to the category. So when I say preferred, like I said, it's very similar to your category 1 recommendations. Preferred basically means that this is a regimen which has a very strong evidence and it has a very good it has a very good balance of benefit and risk, saying that there's probably a more benefit ratio than having more risk. So there is more benefit and comparatively lesser risk or lesser chance of toxicity or lesser chance of some sort of a reaction happening, which is why these kind of regimens would be, again, the first option that you want to choose for your patient. And as you see other recommendation, if it says it's other recommended, you can say that it is valid, but comparatively to preferred regimens, it's not as robust, it's not as reliable. But again, something which might have comparatively less efficacy, but again, it's something that is better than certain other recommendation, which might be category 3 or it'll be in a lower category. All right. And if it says useful in certain circumstances or certain populations, then it is based on a special population that you have. And based on that, you'll be using certain recommendations when it comes to few regimens. But most of the times when we see NCCN guidelines, it's the preferred option that would always want to look out for. And that's the first thing that would actually want to go ahead with. For example, if you see this particular table over here, all right, you can see these are some of the systemic therapy options that is there for metastatic cases of breast cancer. All right. If the patient has for presence of hormone receptors, your ERPR positivity, that is, and if there is negativity of your HER2 or your human epidermal growth factor receptors, then what would be the preferred choice in this case? Then anywhere you see things like category 1 or preferred, for example, we always want to start with the first line agent, which is the most preferred option, like I said. If your patient has no specific germline mutations like BRCA mutations, if the patient has ERPR positivity, and if the patient is HER2 negative, right? Or if the person has low intermediate positivity of HER2, then the preferred option, as usual, would always to be going to some sort of a systemic therapy. And then if the person shows any sort of positivity when it comes to HER2, then it will be something like trastuzumab, which is an anti-HER2 regimen. But imagine your patient comes with a germline BRCA mutation, then we know that PARP inhibitors are the best examples or the best option for your patient. So a drug like olaparib or niraparib, would be some of the recommendations, specifically olaparib being category 1, and this is a preferred regimen option. All right. And if something says other recommended regimen, and if you're, for example, HER2 is saying that IHC is negative, or if it is showing a very low positivity, usually we do not go ahead with a lot of regimens for anti-HER2 therapies in such cases. But if you do not have any option, and if you want to start with trastuzumab, which is an anti-HER2 therapy, then it's a other recommendation that is given, and it's not a preferred recommendation. So that is something which a clinician can take call on, and they can start accordingly based on the benefit that they think is there for is there for their patient. So this is how you see levels of evidence and consensus, and this is where these categories, these preferences play a major role. The next important thing is something called as evidence blocks, and this is something also as a pharmacist, if you ever go through NCCN guidelines, you might want to look at, because this is specific to your certain regimen options that you want to give for your patient. All right. So you see these small boxes next to your regimens. Again, something that I'll probably show you as we go ahead in the guidelines when we practically do it. So you have 5 different components when it comes to your evidence blocks. So what do you mean by evidence block? It's nothing but it's a visual representation of 5 factors, which is nothing but what is the efficacy of the regimen, what is the safety of that regimen that you're going to choose, what is the quality of evidence that is there for that particular regimen and all the other datas and all the other studies that they've done. What is the consistency of evidence? Meaning, if all these studies are being done, is it showing a consistent result in all those studies? And of course, one of the most important things that we need to consider, especially in our setting, in Indian population, would be the affordability. Given that a lot of immunotherapies, a lot of target therapies are actually available, affordability is one of the main things that you want to actually check for. So how do you look at these factors, and how does this influence your recommendation? What do you mean by if something is, 4 points? What if something is 3 points? What if something is 1 point? So each of this has its own, characterization. Each of it has its own explanation. If you see the first one, which is the efficacy, like I said, efficacy is nothing but how well your drug is going to perform in your patient in terms of prolonging the life of the patient, arresting the further progression of the disease, or definitely reducing the symptoms in terms of palliation. If you have all the 5 boxes highlighted when it comes to the E section, right, what you see in the first one over here, then definitely it means that it is highly effective. And this is something that I would want to go for when it comes to my patient when I'm selecting a particular therapy option. And as the number goes down, you see that it's comparatively less effective, and it can be something that can be used not for curation, or it's not something with a curative intent, but mostly to reduce the symptoms and for a palliative kind of an intent, right? So that's where these kind of evidences will help you in terms of efficacy. When it comes to safety, it'll be a little different the way you interpret this, right? When I say safety, it's nothing but I'm talking about what is the chance of a particular regimen causing a certain type of toxicity. What is the possibility that my patient will be able to tolerate this regimen, all right, from a specific kind of combination that I'm going to give. So if you have all the 5 boxes being highlighted, that means it's usually a very safe regimen. It does not have a lot of toxicity, and it will definitely not cause a major issue when it comes to the daily living of the patient. They can carry out their activities, they can receive the regimen, and they can still have comparatively lesser toxicity. But as the number reduces, you'll see that the amount of toxicity that can come up from the regimen can be comparatively more higher. And especially if you're giving certain drugs which will have chronic toxicities or long-term toxicities, automatically you'll see that the evidence block for this kind of a regimen will always have a lower number or a lower kind of a point when it comes to safety factors. Then when I said quality, it's nothing but I'm talking about what is the number and what are the amount of trial studies that I have, or what are the amount of clinical trials that are relevantly present for the particular regimen that you're choosing. Anything which has a higher score is definitely a very high quality kind of a recommendation. This is something that has undergone a very well established kind of a study pattern. A lot of trials have been done. A lot of them have showed very good result. And that's the reason why I would want to go ahead with this kind of a particular regimen option. And as the number reduces, you see that the quality of evidence usually comes down. And this is something that you wouldn't want to rely on because it's not consistent and it comparatively has a lesser quality, and you're not sure how efficacious it's going to be in your patient. So that's where quality plays a major role. And it's not just quality, it's also the consistency that plays a major role, because when I say what is the degree to which this particular regimen is showing me consistency in all my patients, or if a lot of data has been taken for this particular regimen that we are choosing for the patient, if a lot of trials have been done, have they shown consistent results in all these trials? Has all the studies which is backing this particular regimen shown the same results in terms of efficacy, right? If it is having a higher score, then definitely it means that it's a highly consistent kind of a regimen. There have been multiple trials which has shown that this particular regimen that you're choosing has also worked really well for other patients, and it has a similar outcome which you can expect in your patient as well. But as and when the points come down, you can see that it's usually not that consistent, and it is something which is comparatively lesser, what do you say, efficacious, or if it's something which is not extremely relevant. So that's where it becomes a little problematic in terms of consistency if the number of points reduce. So it's not just quality, but also the consistency of the evidence that you're giving for your particular regimen. And finally, one of the most important things that you want to see in your evidence block is the affordability. Like I said, it's not just in terms of what is the cost of the drug, but what would be the required supportive care if they develop some sort of a toxicity. You gave a drug, you caused some sort of a adverse reaction, patient got hospitalized for that adverse reaction, that's going to definitely increase the cost, right? What is the cost in terms of infusion? What is the cost in terms of monitoring the toxicity, managing it, and probably getting hospitalized for it? All of those things have to be taken into consideration. So anything which has a higher point is definitely something that is more cost effective, something that can be considered even in low income patients, but something which has a lower point, right? So that is something which will be comparatively a bit more expensive. Things like your immunotherapies, target therapies have very good data, work really well, but really not affordable by a lot of patients, because the amount you see for a lot of your immunotherapies, they kind of span in a lot of lakhs of rupees. And that's not something that we can expect every single patient to afford, right? So that's where affordability is one of the things that you as a pharmacist has to also take into consideration. And that's where your evidence blocks are going to make a big difference. And if you can see this particular table that I put across over here, this is an evidence block I picked for all the adjuvant therapies or the neoadjuvant therapies we can have for breast cancer patients who are hormone receptor positive and HER2 negative. Simple regimens like your, if I can just zoom in, I think this would be a little bit easily visible. Is it visible to you guys?
So it's visible.
Okay. So the same thing what I just explained, right? You can see it on the top over here, right? For example, if you would want to start something like a dose-dense AC regimen, which is nothing but your doxorubicin with your cyclophosphamide, followed by paclitaxel every 2 weeks, or you want to start with weekly paclitaxel. So these kind of regimens are something which you see that, they comparatively have a very high evidence, which is really good for you. And this is something you see very commonly in a lot of patients. Safety, of course, is not meeting the 5 out of 5 category, because as and when you add more and more drugs, the risk of toxicity does increase, but these are toxicities which can be usually managed if you can start with an appropriate pre-medication, or if you can catch certain symptoms of certain areas at the earliest. But if you see one of the most important things, that is the quality of evidence and the consistency of evidence, these two columns are 5 out of 5, which is what we actually want for our patient. The higher the evidence, the higher the consistency of the kind of studies that are supporting this kind of a regimen. That means it will work pretty much really well for your patient if you select it appropriately, right? So that is something that is important. Affordability wise, of course, the more regimens that you add, the more drugs that you add into a regimen, there's a high possibility that the cost can increase. But generally, if you see most of the chemotherapy agents, they are quite affordable. And especially if you have lower income patients, they're mostly on a lot of schemes when you see in your hospitals, which is why affordability is not usually an issue when it comes to these kind of regular or your conventional chemotherapy agents. But if you see for drugs like immunotherapies or targeted therapies, it'll hardly be just 1 or 2 points, because these are actual regimens which have issues when it comes to your affordability. But this is just a table I'm showing you as to how you can actually use this in your NCCN guidelines to kind of select a particular option. Again, if you just see an example at this point, so what I just showed you was for your AC regimen, which is a regular type of a regimen. But take a drug like olaparib, which is a targeted therapy, and you see the cost of this, right? It's just 2 points compared to the 3 points which is there for AC regimen. And again, the kind of evidence that you have is 4 out of 5, which is, again, it's a very good drug if you have a patient who's coming to you with BRCA mutation. But then if somebody is coming to you with hormone receptor positivity, which is what we're seeing here, then I would definitely go ahead with my conventional chemotherapy followed by an hormonal therapy option based on the menopausal status of the patient, right? So that's where these kind of tables help you make a decision as to what is the best thing that I can choose for my patient. And as a pharmacist, I definitely feel that these evidence blocks are a game changer because they definitely give you a much better insight rather than sitting and reading individual articles or individual, studies. You can just go through these evidence blocks and you can kind of get a very quick reference as to which is the best option that you have, available for your patient at this point. And that's where evidence blocks play a major role. Okay. So if you guys are following till now, again, how do we start reading an NCCN algorithm? So when we start looking at the PDF, I think you'll again get a much better idea. But the first thing that you would always want to do in terms of any sort of a cancer case would be to always start with the workup and to stage the disease. When I say workup, when I show you the particular regimen, the particular guidelines, and then when it comes to seeing what is the type of diagnostic approach that I want to have for my patient, then the most important thing is which is the most relevant type of diagnostic approach, and am I able to see all the features of a particular tumor that I'm looking for in terms of the size of the tumor, the depth of invasion, is there any presence of lymph nodes, is there possible metastasis to other places in the body. I can do this in terms of doing a simple ultrasound. I can do this with as complex as a breast MRI or a PET scan. So all of these things will kind of give you a basic workup, along with the other types of diagnostic approaches that you can have in terms of simple CBC reports, RFT reports, LFT reports, which you're doing as a basic workup, as a baseline workup for your patient. And of course, once you confirm that with a histopath or with a biopsy, you have a confirmation that this is malignancy, and that will help you to stage your patient. And once you stage the patient, the next thing that you want to do is go as per the decision notes or the arrow marks. And along with that, consider the footnotes and see which is the best option that you want to go ahead with as part of your therapy recommendations. And finally, when you identify the appropriate treatment branches and the recommendations, you try to implement that in your patient and you follow that up for a while and you see how the patient is responding. And based on the response, you're going to make further interventions. And for that, is why it's very important to go through an algorithm because it kind of gives you that flow and it kind of gives you that streamlined treatment decision option when it comes to choosing particular regimens. So what are the key sections in an NCCN document? Of course, the workup and the diagnostic evaluation, which we'll also be having a look at. And based on this, like I said, you can stage your patients, especially if it's a solid tumor. We do something called as TNM staging. And if it's a hematological tumor, then we stratify them as per the risk when it comes to a lot of your hemat tumors. So you can stratify them as low risk, intermediate, or high risk instead of staging them, which is unlikely in terms of liquid cancers. And then, of course, based on all of this, the first thing you want to do is what is the regimen that you would highly recommend for your patient? So the first line would be something that you would select, and you will see all these evidence blocks. You'll see all these different options that you have, and you'll see which is the most appropriate one, and you'll start off with that. And as and when the regimens are, completing, you actually do something called as a response assessment, and you see how the patient is responding. If you feel that the patient is going into remission, if you feel that the patient is having a very good controlled disease, then regular surveillance and you're trying to identify recurrence pathways as to what is the risk of recurrence. You can carry out certain prognostic scorings, and you can actually find out what would be the next decision that you can take in terms of observing the patient going ahead. So these are all some of the key sections that you'll actually see in NCCN guidelines. So that is just a basic introduction. And again, how do you access NCCN guidelines? Well, of course, NCCN is something that is a free access. You go to this particular website, nccn.org. And the best part is it's free of cost. There's nothing that you need to pay. You can register for free. And this is something which, if you register as a student or as a healthcare professional, probably once every year, you're supposed to just update your data, and there's no specific payment that you're supposed to do, which is why it is very easily accessible and it's very easily available to most of the students and healthcare professionals. And once you have access to this, it's very easy to download most of these PDF versions, which you can keep using for educational purpose, like what I'm doing right now. or you can use it, of course, for making certain treatment decisions. But of course, you need to also understand that these guidelines keep undergoing very regular updation. So you need to keep checking when was the recent most guideline that was updated. And we always recommend that it's best to use the most latest version. For example, if you see for breast cancer, I think they already had around some 5 updations just in the year of 2025. So you have 5 different versions for just breast cancer guidelines when it comes to NCCN. So you can imagine the kind of updations that you get for all the other guidelines when it comes to all the other organ cancers that you see in NCCN guidelines. So it's easy to download, it's easy to access. And of course, you have even the mobile application that is available. And if I'm not wrong, even in the mobile application, you have access to the CTCAE guidelines, which is nothing but the common terminologies that we use for cancer associated adverse events. So the recent version of CTCAE 6.0 has also come out, probably in the month of July this year. So a lot of these kind of resources can be accessed through the NCCN mobile app as well. You have a lot of patient-friendly versions as well, where the same data is put up in a much more simple language, in a much more layman kind of a language. You don't have a lot of these jargon terms being used for all these leaflets and information documents that are there for patients. So you can use it for simple information as well. Updates and version, like I said, they're always constantly updated because some of the other new trial keeps happening, new approvals keep happening, which you guys keep seeing very regularly. And of course, like I said, the year and the version number that you're using is very important, especially if you're planning to cite it in publications and certain presentations, because these are things which, like I said, keep getting constantly upgraded. And it's always important to use information that is that is the most latest and that is the most recent one. And of course, refer to the newest version, like I've been saying, so that you avoid any outdated information. And one of the other things which I can show you probably in some time, if you have a little bit more access to time, is this NCCN Guidelines Navigator, because we saw all these PDFs. They're quite complex. They're quite elaborative. But NCCN Guidelines Navigator is something which makes it a little bit easy, and it's an interactive kind of a tool which is given by NCCN. So probably for the same case, which we will discuss later on, we can have a look and it becomes a little bit more easy to understand. So we'll have a look at that as well. And what is it that NCCN does not provide? Of course, it will not tell you about what is the regional availability in your specific place or in your specific area. What is the accessibility to certain medications? These are things which is generally recommended as to what is the best option that you have for your patient. And when it comes to availability, that is something which it cannot give you information on, because this is a global guideline when it comes to implementing certain therapies. And it, of course, will not replace certain institutional or local treatment pathways, because certain institutes, based on their clinical experience, based on their protocols, they have recommendations which might work a little bit more better, which is why I also said that clinician-based decisions can also vary from the guidelines. But definitely, to make these protocols in an institute, you do require a guideline like NCCN to see the evidence. So that's where it is very important. And of course, clinicians will use a lot of these guidelines, but sometimes they'll have to integrate a lot of other practical constraints like finances. You can't really expect every single person to afford immunotherapies, targeted therapy. So in such cases, one of the things would be to go for a simple conventional chemotherapy, which might give you comparatively a better disease control, but not as good as what an immunotherapy or a targeted therapy would. And you have to consider other patient specific factors like comorbidities or conditions like pregnancy, and see what is more appropriate for them. So that's something which NCCN can provide, but not elaboratively at times, especially when it comes to things like finances. But looking at recent recommendations like your evidence blocks, these are things which can also help you in terms of affordability, which is actually not really what do you say, a factor that is missing out in NCCN anymore. Limitations, of course, some recommendations will rely on limited or lower grade evidence, which is very few, because 90% of the evidence that NCCN gives is very good. So limitations wise, this is quite rare, but it definitely is there if there are no options available in certain conditions. High cost or unavailable options might be preferred options, like I said, because if you say that a patient is metastatic cancer of a specific organ, most of the times reaching out to immunotherapies and targeted therapies would be preferable. And these kind of options might not be available, they might not be affordable by a lot of patients. but the guideline says that this is the best option that you have. So in such cases, it's very tough to take decision, but that is a limitation, which is something, again, it varies from region to region as well, but that has to be taken into consideration. There are certain things like, for example, you have certain off-label indications, which clinically it is doing really well. If you have seen cases of triple negative breast cancer, we commonly see that your platinum drugs like your carboplatin actually has very good evidence. It works really well, but it's not something which is standardized as part of the guideline. But they do give you off-label recommendations as well, which is not a bad thing. It's definitely not something which is not reliable. It is just that it's not a indication that is well established, but definitely as per the clinical use and the evidence of late, drugs like carboplatin have worked very well and have worked fantastically for triple negative breast cancers. But whenever you see TNBC, of course, the option would be to go for a BRCA testing, to consider options like olaparib, right? So these are some of the FDA recommendations that have also been given. So you do get to see certain off-label recommendations as well, which again, you have to weigh the benefit from risk and then choose these kind of options. And definitely it's not intended to replace any clinical judgment. It is just helping to guide a clinical judgment, because these are things which have to be considered, but not 100% or strictly followed. So that is something which is also sort of a limitation, but again, not a negative point or a disadvantage. When can you integrate this into practice? Of course, if you're looking at complex cases, if you're looking at cases which require a multidisciplinary kind of a overview. So in MDT, in your MDT meetings or in your multidisciplinary tumor board discussions, these are places where NCCN can help you make a better decision, right? So that's where it can actually be integrated. And making hospital protocols which align with these kind of recommendations is one place where NCCN plays a major role, because certain recommendations when it comes to your clinical pharmacy departments or your pharmacy practice departments, we can use these things where oncopharmacists can integrate some of the recommendations and make their own protocols which are aligning with what NCCN is saying. So definitely, not just for clinical pharmacists, but also for oncologists, these kind of recommendations are highly helpful to take certain decisions. And like I said, it's not just your pharmacists, oncologists, but also your nurses when it comes to probably the administration of medication. Though we don't have very elaborative information on how to administer certain medications when it comes to NCCN, it definitely can help understand what are certain order sets. How do you counsel a specific medication? What is a workflow that can be expected? Which medication can be started first? Which medication can be given after this? So those kind of information can help the different healthcare professionals as well when it comes to integrating NCCN. Global practice, of course, this is something which has been used not just in US, but all around the world. And definitely with my own experience, I've seen a lot of oncologists use NCCN. And personally, from my experience of using NCCN, it is a highly reliable kind of a alliance or a guideline that has helped us make certain good decisions for the patients. And it has definitely had a very good outcome for the patient as well when we have recommended regimens based on NCCN. And it's not just about one specific guideline. As I said earlier, in certain footnotes, you can also see certain guideline recommendations given by your ASCO or your ESMO, which are all your other American and your different European organizations when it comes to medical oncology or clinical oncology. So they would have presented certain data, they would have presented certain information specific to their population. That is also taken into consideration, and in combination with these recommendations, NCCN can have a much more stronger evidence, which is why it's not only one set of data that they look into. They also do take other studies from other regions into consideration as well, which is why it is very reliable for global practice. And of course, when it comes to things like your evidence blocks, especially when it comes to things like affordability, if you're looking into options when it comes to your low income and middle income countries and how to modify certain drugs in terms of accessibility, how to modify certain treatment decisions when it comes to choosing certain therapies, that is where NCCN can also play a role, where it can also help you give a better recommendation, which can be more cost effective as well for population belonging to these kind of areas as well. When it comes to future of NCCN guidelines, definitely we see that artificial intelligence is something that is being integrated into a lot of places, and NCCN is definitely one of those areas where artificial intelligence is slowly moving into, because it's going to make it much more easy to use. It's going to make it much more reliable. Of course, it's going to give you a little bit more comprehensive data when with the help of AI. And definitely genomics, as Dr. Tejaswini earlier as well, she explained about the whole concept of pharmacogenomics. Genomics, tumor profiling is definitely the future of cancer therapy, cancer diagnosis, adverse reactions related to cancer therapies, and definitely incorporating those kind of recommendations, incorporating certain mutations which can be germline or somatic, which can kind of also influence the treatment decision. That also will be something that can be possibly integrated into the guidelines going ahead. And of course, expansion of biomarker driven or tumor related or tumor based recommendations is something which they have always been doing and will definitely keep doing going ahead as well. And more real time updates based on the kind of evidence that keeps coming up, because we see that a lot of guidelines are showing up. I mean, not a lot of guidelines, a lot of studies, a lot of trials have been conducted when it comes to cancer therapy, when it comes to a lot of options that we're using in cancer, and all that evidence has to be put into one place because it's quite difficult to access them at times. But incorporating those with the help of AI, with the help of certain technological advancements, can make it much more easy for using NCCN and much more reliable and more standardized, which is why having all these updates, which have been constantly, coming into the today's therapy and the kind of scenario that we have. So that is something that also is promising when it comes to NCCN guidelines. So before I take up the case, so just to summarize, NCCN is definitely one of the cornerstones in terms of modern oncology practice, and it's something that is very commonly used. If you have ever seen your oncologist, if you have seen your clinical pharmacists, NCCN is something that they would definitely rely on, and I would recommend that everybody would definitely refer to this when it comes to actually making certain treatment related decisions for your patients. Understanding the structure and the approach is something that makes it more easier, and the kind of treatment decisions that you take will become a little bit more efficacious and more efficient, right? So if you make a regular habit of using this, if you kind of understand how to navigate through the guidelines, so it is something that's going to help you make much better decisions when it comes to selecting certain regimens as a pharmacist, as an oncologist, or any other healthcare professional that you are. And of course, you always use the most recent version, and that is something which will have the most latest update. It'll have the most latest evidence, and it'll also be something that you'll have to consider in terms of the local context, which is more kind of relevant to your patient or relevant to your population. And like I said, I always encourage the regular use. And even for me, if as and when I keep using it regularly, that's where I get to know more and more about NCCN, especially, for example, your NCCN Guideline Navigator, which is something which I recently came across. Instead of having this elaborated PDF, having something which is more interactive is more easier to use. So these kind of things, if you use it regularly, you adapt quickly. You see that it's not actually that difficult sometimes to use these guidelines. Of course, you will get confused in between. Even for me, it gets confusing here and there at times, but these are things which can be easily navigated through if you know the basics of how to use this particular guideline, right? So regular use can make you a little bit more efficient in understanding how is it that your oncologists are actually choosing the therapy, how is it that they're making certain treatment related decisions based on the staging, how is it that they're actually staging your patient, how is it that they're actually choosing which is the next type of diagnostic technique that I need to use. That's where when you use these kind of guidelines regularly, you'll be able to understand those kind of decisions much better, right? So this is just the basic of your NCCN guidelines, and of course, these are some of the most important components when it comes to your NCCN guidelines. So what I thought was I'll just take up a small case and I'll just explain you. We can try to keep it a little bit probably interactive, but I'll quickly explain this case. And I've just formulated this case based on one of the patients we had recently in the hospital, right? So this is just a simple breast cancer example, which will actually incorporate into NCCN. And of course, before actually I go into this case, let me just show you the guidelines on the website so that you actually know how it looks, right? Any doubts that you guys have till now? Is it okay if I keep going ahead, or do you want to ask me anything before we go ahead? Are you all able to see my screen again? Are you able to see the guideline page? Hello.
Yes, sir, it's visible to all.
Okay. All right. Is there anything you guys want to ask before we move ahead? Because I know it's a lot of information. Um, okay. Just give me 1 second. Okay. So this is how your NCCN guideline would actually look like, right? I think a part of this is getting cut off. Let me just get back to this. Yes, I think this is a better view. So yes, so this is how the homepage of your NCCN guidelines would look. Of course, you have your login over here. So my name is appearing over here because I've already logged in into the website. Okay, let me just log out to show you how it actually looks so that we go a little bit step by step to understand this a bit better. Do bear with me because it might take a little bit of time for the guideline to process. It is a little slow at times, but it's better to actually go through this a little bit extensively. And we'll try to wrap this up in the next 20-25 minutes, hopefully. Okay, I think this is going to take a bit of time. I've anyways downloaded these PDFs to explain it so that we don't have to wait for this. But if you remember the first few slides, right, this is what I'd shown you. Like, this is how you look at the guidelines. You see what are the different types of cancers that you want to talk about. All right. And looking at the case that we have, of course, we'll choose breast cancer. So when I choose this, it's going to take me to a different section where you have a PDF, which is basically the NCCN guideline that you want to look at. You have the evidence blocks. You have a separate PDF for patient related information. You have different PDFs for different conditions. I mean, sorry, for different recommendations. But this is how the treatment by cancer type, this is the main part that we'd actually want to look at. And as I said, you also not just have for your cancers, but also for your different kinds of supportive care managements or palliative care management, survivorship care, treatment of certain issues related to your drug toxicity, those kind of things as well. And this is also the section where you get to see what are the different strategies or different guideline recommendation when it comes to your early detection, prevention techniques, risk reduction, all of that. All right. And then we have the NCCN Guidelines Navigator. I hope the internet is a little bit faster and a little bit kind at this point because I really wanted to show you this navigator because it's quite interesting. But let's get back to that. But this is how generally your homepage would look, and this is where you want to actually go to. That is your guidelines. You can click on it and it'll take you to these things, or you can just put your cursor on it and you can actually see that just by placing the cursor, you can actually access this. So based on the cancer you want to go for, you can just click on it and you can actually start. So now if imagine, I clicked on breast cancer and that specific PDF, then this is probably what would actually open up. All right. Again, I'm just asking to confirm you guys are able to see the screen.
Yes, sir, it's visible.
Okay. So this is how breast cancer NCCN guideline would look. Like this, you have all different PDFs for different cancers. Like I said, these are downloadable PDFs. These are things which can be easily accessed. And if you just see the first page, right? One of the main things that you need to see is when was this actually, uploaded or when was this actually published? And it's as early as, less than 2 months back that these recommendations have been given. So it's the most latest, it's the most relevant. And this is, like I said, probably the fifth version that has come out just in this year. All right. So this is a guideline that I would want to go for because this is something which is the most recent one, right? So this would be a little bit more helpful for my patient and it will have more recommendations. Okay. And of course, as you continue through the guideline, I'm going to quickly skim through it. These are all the panel members who are definitely putting their contributions into this entire breast cancer guideline. And this is the main index page where just by clicking at one specific component that you want to look into, or one specific section you want to look into, you can actually directly jump to that. But that's something we're going to try to do a little bit lesser, but of course we have to do that at certain times. But this is something which is your main index page where you get to see what are all the different components when it comes to just your breast cancer guidelines, right? I'm going to use this so that you understand better. And when you come to the next page, these are all some of the updates. I know it's a little smaller. Let me see. Yes. These are all some of the updates. As you come to the second page or the third page, you see that, you have different updates. What are the updates that have been included this time? What are the updates that have happened? What are the things that have been removed, added? And you will see specifically as per the page number. And here the page numbers have alphabets and numbers. They're alphanumerical values. They're not just a simple page number 1, 2, 3, 4. So whenever you see all these guidelines, you'll have different types of page numbers, which will kind of give you an idea what it is actually, talking about. So this is something that you get to also see in your guidelines, the latest updates. So there have been quite a lot of updates, just in this particular year, starting from the version 1, which has happened, right? And from the 2024 version. So these are all some of the things that you can actually also look into, but something, of course, it's not something that you want to actually go very much in depth about, but something to show you that these are the things which are very transparent and a lot of recommendations are as per the latest guidelines, right? Okay. So this is where you come to, and like I said, this is your algorithmic flow chart. You have your footnotes, you have your treatment recommendations like you see over here, your category 2B, your category 1. What are all this? We're going to come back to that. So let's use this particular case that I have over here. Okay. And let's try to navigate through the NCCN guidelines so that it becomes a little bit easier for you to understand what exactly it is that we're talking about when it comes to deciding a specific treatment, right? Of course, if it's just one single case, it might not be uh, possible for you to understand everything. That's why I've taken a very simple case since we have a lot of students as well. And it's a little bit easier to understand when I kind of show you realistically how is it that certain recommendations are made. Okay. So let's just look at the simple breast cancer case. All right. So I'm going to briefly explain it. It's a case of a 48-year-old premenopausal woman who presented to the medical oncology department with a very small palpable mass, which is present in the upper outer quadrant of her left breast. She has no significant family history of any breast or ovarian cancer, right? Given that BRCA mutations are something which is quite common when it comes to these two organ cancers. And of course, she does not have any significant comorbidities in terms of any diabetes, hypertension, thyroid issues, or any of those other comorbidities which we need to be worried about. One of the other biggest advantages is that she has no financial constraints that she reports. And we can also consider that, she does not have any social history, though I forgot to mention over here. So looking at this specific case example, the first clinical presentation that she came to was with a palpable lump, which was there in the upper outer quadrant of the left breast. There was no adverse features of any sort of nipple discharge, skin retraction, nipple retraction, or presence of any axillary symptoms in the lymph nodes. Because every time we talk about cancer, it's not only about the primary tumor. We also need to know what is the lymph node status, because that is one of the primary sites where the whole concept of spread or metastasis can start from as well. Right? It cannot be only your hematological route, it can also be your nodal route, which has to be taken into consideration. And as and when you see that lymph nodes get involved, you see that the stage automatically goes up, and the kind of therapy options that you have kind of becomes a little bit more advanced, and it kind of becomes a little bit more lesser in terms of local options. So that's where your lymph node status plays a major role, and that's exactly why we have taken this into consideration over here. Okay. So patient said that, I've been having these symptoms. I was taking shower, and that is when I found that, there's a palpable mass, and I was concerned about it. It was movable. It was irregular in shape. It is something which I just recently noticed. I have no idea what it is. And with all these complaints, patient ended up coming to MedOnc, and then they carried out a simple physical examinations looking at all these symptoms. They saw that there is presence of an irregular mass, which is measuring approximately 2 into 1 centimeter, which is there at the 10 o'clock position in the left breast. They also palpated the axillary lymph nodes, and they found that there's nothing significant. And every time you do on one of the breasts, you also have to do on the other side as well, just to see if there is any possible involvement. So the right breast was found to be unremarkable, along with any sort of right lymph node involvement. They did a simple pickle status and they found that it was found to be negative, right? So now looking at all of this, the MEDONC decided that, let's go ahead with further imaging. So given that there is involvement of the left breast, let's study both the breasts. So they have gone ahead with a bilateral ultrasonogrammetry. It showed that there's a hypoechoic lesion that is there, which is 2.4 into 1.3 centimeter. I want you guys to remember this size because the next thing I'm going to take you through is staging so that we come to a stage and then we start looking at the recommendations. Okay. So there's a hypoechoic lesion, which looks a little bit darker than the background. It is irregular in shape. It is the largest diameter is around 2.4 centimeters. It is seen in the upper outer quadrant of the left breast. There's no significant axillary lymph node involvement in the left side where the tumor is. And on the right side, you see that it is absolutely normal and there's nothing to be concerned about. But when you see the BIRAT scoring, it says that it is BIRATS 4C. Anybody has any idea what is BIRAT scoring? Students especially. And if my students are there, please don't answer because I'm definite that I've explained this concept to you guys. But if anybody else is there who has any idea about what is BIRATS, what do you think it is? Let's try to keep it a little interactive so that you're understanding what I'm trying to do over here. Okay. So BIRATS is basically kind of imaging kind of a classification. They're talking in terms of what is a characteristic of your tumor. So BIRATS has a score of up to 6, where up to the score of 3, you say that usually it's some sort of a benign finding. But the moment it turns BIRATS 4, right, you're kind of suspecting it to be a little bit more malignant. And again, you have 4A, 4B, 4C, where 4A and 4B has somewhat 50% chance, but the moment it turns 4C, it's almost up to 95% chance that this can be malignant and not benign. Until and unless it is a score of 3 or 4A, you can say that, you don't necessarily need a biopsy to confirm this. You can just undergo regular screening and see if there are any further changes. Okay. But the moment it is 4C or BIRATS 5, there's a very high chance that it is malignant. And this is what helps you, kind of decide that, you need a biopsy or not. So to tell if you need a biopsy, BIRATS scoring becomes super important. And that's where your entire imaging plays a major role. All right. So they've done a BIRATS score and they found that it is 4C, which is almost more than 50% to almost 95% chance that it can be malignant. So doing a biopsy to confirm it, which is a gold standard when it comes to cancer diagnosis, is supposed to be considered over here, right? So that is what is BIRAT scoring, which kind of tells you, do you need a biopsy for your patient or not? Okay. So then again, to further confirm it, they've done a MRI breast. They found the same lesion in the left breast, which is approximately measuring the same. All right. There are no other lesions that is seen around the left breast. It is multifocal. I mean, it's not multifocal at all. It is only in a specific single lesion area that is there. Then they also carried out a PET scan, which is for your entire body. And whenever you do an ultrasonogrammetry or an MRI of breast, it's only for the breast that you're actually carrying out the imaging to see what exactly is the tumor and how exactly is the tumor involved only in that local breast area. But you also want to see what is the metastatic workup, or you basically want to carry it out to see if there is presence of tumor throughout the body, because this is where your entire stage is going to change as well, right? So when they carried out a FDG PET CT of the entire body, they found that, there is a lesion, the same thing in the left breast, and they found that it is hypermetabolic, which means that it has a high metabolic activity, and there's a standard uptake value, which is of almost 14 and above, which is usually very significant. And if you have a value of more than 2.5 or 3, it can tell you that it's usually it's a possible cancerous lesion, which is highly metabolic in nature, which is something that we know very well what cancer cells do, right? And they found that there's no other adverse features like fat stranding or perilesional stranding. They found that the left axillary lymph nodes were unremarkable without any significant uptake. And there was no other findings in any of the other organs in the body. Okay. And now they carried out your regular CBC, LFT, RFT, 2D echo, which are all your baseline tests, and they found that there were no anomalies. Patient is fit enough to go ahead with all the therapies. Okay. So now just looking at this data, all right. I told you earlier about something called as TNM classification, which is nothing but what is the feature of your tumor in terms of the size, what is the nodal involvement that you see for your particular patient, and what is the metastatic status, if there is metastasis or not. Now, just by looking at this particular tumor size, right, we can tell what is the T status. We know that there is no lymph node involvement. So we can actually tell what is the N status. We have done an entire body scan, right? So we can tell if there is metastasis or not. So as per what I'm seeing, there is no specific metastasis. So this TNM classification is something that is actually going to help you stage your patient, right? So now when I open the TNM classification, if you go to your index page, and if you click on the staging, which you see at the bottommost right over here, right? You click on the staging. What is the size of the tumor? The largest size, it was 2.4 centimeter. All right. So I would say that this would be a T2 kind of a tumor, which means that the tumor size is more than 20 mm, which is nothing but 2 centimeters, but it is less than 50 mm, which is less than 5 centimeter in its greatest dimension. So the 2.4 or 2.5 centimeter that I have for my patient will lie within this particular range, which is why it kind of makes it a T2 kind of a tumor. All right. So remember this, it is a T2 status. It does not belong to any of this because the kind of factors, the kind of size, the kind of characteristic features that my tumor is showing is kind of more relevant for this T2, right? And then coming to the nodal status. We also know that there was no nodal involvement, lymph nodes are completely unremarkable. So it's a very easy thing to understand, all right? Which means that it's a N0 kind of a disease. Before actually going into this, I'm just going to simply explain what does these things mean and what are all these different things, right? When I say TNM, it basically means that T, like I said, talks about your primary tumor. What is the size? What is the depth of invasion? What is the different features it has? So that can vary from T0 to T4. All right. So higher the tumor size, higher the depth of invasion, more is the scoring. If it says TX, it means that it cannot be assessed. All right, because it is not clearly visible, or it is not easily accessible, or there was no sort of imaging done at all. So you could not assess it. And if you say T0, which is something which we usually don't see, but you do get to see it in cases of unknown primary. All right. So T0 means that there's no evidence of primary tumor, which is something good in terms of response that you get for your therapies. All right. So these are all the different kinds of classifications you have for your T status alone. You have a similar classification for your N status, where NX means you can't assess the lymph nodes. N0 means there's no lymph node involvement, which is what is relevant to our patient that we're looking at the case right now. And based on the kind of lymph nodes that are involved, you'll start from N1 to N3. All right. And what I'm trying to say over here is these characteristic features vary from cancer to cancer. They don't stay the same for each cancer. Because if you see, for example, for a colorectal cancer, it might not be in terms of only the tumor size. It can be also in terms of the depth of invasion or the kind of layers that it is involving within the colon. Or if you see head and neck cancer, you'll see that it's not only about the size again. It's also about the anatomical involvement that is there, right? So TNM classification varies from cancer to cancer, and not every guideline will have the same kind of features. But what we are discussing for breast cancer, that is the reason why I'm showing you this. So as per our understanding, we know that our patient belongs to N0 because we know that there is no regional lymph node metastasis or involvement that has happened in the imaging or the clinical examination that we found. All right. So that is what we saw for our patient. And then I told you that we have also carried out a entire metastatic imaging by doing a PET scan. And we clearly found that there's no clinical or radiological evidence of distant metastasis or involvement of any other organs, which is there in this patient, right? So now if I have to classify this patient in terms of TNM as per what we have seen, all right, then I would say that this patient is a T2, N0, M0 kind of a case, all right? And now looking at this T2, N0, M0 kind of a combination on the right side, right? So the AJCC classifications will put it into specific stage. So now if I say T2, N0, M0, which is what is there for our patient, which I've highlighted over here, right? So that will put my patient into a stage 2A kind of a cancer, which is kind of an early tumor, right? There's no involvement of a lymph node. There's no distant metastasis, and tumor is more than 2 centimeter, but not more than 5 centimeter, which is why it is T2, N0, M0. And finally, how do you stage this? You combine this and you call it as a stage 2A kind of a cancer. And that is where you actually start off from, because based on this TNM classification, you will be able to understand how do I move ahead next, right? So that is exactly what is being done in this case. All right. And of course, if you want to confirm that this is a tumor, you can't just radiologically confirm it. you have to carry out a biopsy, and that's where your biopsy report will tell you what kind of a cancer it is, what is the grading of the cancer. And then when you send that sample for immunohistochemistry, it's going to talk to you about your surface receptors, especially your hormone receptors, right? So for this case, it said that when they send the biopsy sample of that particular tumor, it was a moderately differentiated, that is a grade 2 kind of an invasive ductal carcinoma. I have forgotten to mention the word carcinoma over there. All right. So then when they send that particular sample for IHC, they found that it had a very high scoring in terms of the ALRED classification. So in terms of ALRED classification, if the score is 3 and above, they usually say that it's highly positive. So in this case, it is ERPR positive, and it shows that there is a high expression of your different hormonal receptors. And this is also important because based on this, you're going to actually be choosing your hormone therapies, right? And then they did a HER2 assessment as well, which was found to be with a score of 0, and that is negative. And they found that the Ki-67 was moderately elevated, which is around 22%. Okay. Now, looking at all of this information, looking at whatever we have, like I said, we're able to stage our patient as a stage 2A patient, which is T2, N0, M0 kind of a scenario that we have for our patient. So how do we go ahead when it comes to this particular thing? All right. Given that it's an early cancer, one of the first and the most important or the most relevant option that I would want to go ahead with is some sort of an upfront surgery because the tumor is small. All right. You want to remove the tumor as much as possible. So surgical option would be something that would be more relevant in this case, right? But the patient here says that, okay, they want to have a minimally invasive kind of a surgical option, given that, there is some concern with the aesthetic appearance of the uh, tissue which comes up after the surgery. So given that they want to go ahead with something that is minimally less invasive, so you have different surgical options. You have lumpectomy, which is also called as breast conservation surgery. You have mastectomy, which is complete removal of the breast, right? So these are all the different options that you can have. You have simple mastectomy, you have a modified radical mastectomy, right? You have complete axillary lymph node dissection that will be done, or a sentinel lymph node dissection that will be done. So all these things will be based on the patient preference, and it will be also based on what is more suitable for your patient. So in this case, now looking at this entire thing, we're able to say that it is a T2, N0, M0, a stage 2 kind of a case. The medonc is deciding, okay, you know what, let's go ahead with a surgery upfront. So they want a minimally invasive kind of a surgery. So the first thing that they considered doing was a lumpectomy or a sentinel lymph, along with a sentinel lymph node biopsy or sentinel lymph node dissection. Okay. So now I'm just going to go back and I'm going to show you in the guideline how it's actually going to look. Okay. So as I said, since this is an invasive breast cancer, so that is the thing I'm going ahead with. So we have an invasive cancer, all right. We have taken the history of the person. We have done an imaging with a bilateral mammogram, which is done in our case. We have done a breast MRI, which is optional, but it was still done in our case. They've done a pathological review, which confirmed that our patient had a moderately differentiated invasive ductal carcinoma. They sent that for IHC and they found that ERPR was positive and HER2 was negative. Of course, we don't have any information on the genetic counseling. They did not give any information on addressing regarding fertility and sexual health. All right. Especially if it's a very young patient, this is something that you have to definitely consider. Okay. So all the main things what you see over here was done. Rest of the things what you get to see over here is something that is actually uh, more specific to your patient if you want to choose it, right? So in this case, most of these things have to be considered as well, but most of the most vital information that we want to take is the history and physical examination, the imaging technique, the pathological review, and the hormonal receptor status confirmation. Okay. So all these things, what you see that I'm highlighting over here, okay, is kind of being done for our patient. So now looking at all of this, we saw that, okay, patient is T2. So definitely this will not be the node that I would want to go for because it's T0. So something that is T2 will fall between T1 to T4, right? And we know that it is N0. So if you imagine even it was N1, N2 or N3, you can see this particular symbol over here, which says that more than or equal to. So this considers all the lymph node status. Okay. And we also know that our patient is M0, which means that patient does not have metastasis. So definitely this would be the pathway that I would go with, right? Similarly, if I said the patient had metastasis to different organs, then automatically it would come to this particular pathway. because this is something that is regarding your metastasis. So I would go ahead with this particular link over here. All right. So in this case, finally, this is the pathway that I feel is more suitable for my patient because it's a T2, which falls into your particular criteria here. It's an N0 disease and it's an M0 disease. One thing I want to check is my patient a candidate for receiving preoperative therapy? All right. If I click on this, it's going to take me to a separate page where it talks about what are the criteria or what are the factors that will put your patient as a good candidate for preoperative therapy. Of course, if the patient has invasive breast cancer, that is one thing, but it's not the only recommendation that you want. If the person has presence of multiple lymph nodes, right, that can be a reason why you want to start a preoperative therapy to shrink it and then follow a surgery. But we don't have this in our case, right? We don't have lymph node involvement at all. We don't have an N3 nodal disease, and we know that ours is a T2 case and not a T4 case, right? We know that our patient is not HER2 positive. We know that our patient is not triple negative because our patient is ERPR positive and HER2 negative, which is not at all TNBC. We know that our patient does not have a large primary tumor. We know that there is no involvement of lymph node, right? These are all some of the things which is not at all meeting our criteria. So I would automatically say that, you know what, my patient is not really a candidate who requires a, preoperative kind of a therapy. So I would consider it as not considering preoperative systemic therapy in my case. All right. So in this case, just give me 1 second. So yes. So in this case, like you see, we are not considering any pre-systemic therapy. And patient was saying that they want a very minimally invasive kind of a surgical option. So this is where they would want to go for something like a breast conserving surgery. Because if I say mastectomy, then mastectomy becomes complete removal of breast, and that will have issues with the aesthetic appearance. But since our patient is saying they are worried about the aesthetic outcome, then breast conserving surgery, along with surgical axillary staging and possible whole breast radiation, is considered. Because whenever we talk about breast conserving surgery, automatically it's one of the deciding factor to start radiation. So this is the next thing that I would actually go ahead with. All right. So once I click on that, it takes me to this particular page. All right. So now if I say that these are the options for my patient, okay, I have done a breast conserving surgery, all right, and I have found that the patient has also undergone axillary staging. There is also an oncoplastic reconstruction that is considered, which is actually quite helpful for our patient. Because if I say reconstruction, that is actually to kind of preserve the aesthetic appearance as well. So something like a plastic surgery, right? So all this is done. The next thing is to actually start with an adjuvant therapy as per the note that you see over here. All right. But before considering an adjuvant systemic therapy and before going ahead to radiation therapy, we need to understand what is happening in the surgical histopath, right? So whatever breast conserving surgery was done, that is lumpectomy, and whatever sentinel lymph node biopsy was done with the first few lymph nodes that were dissected, then this was the histopath report that came up, which has said that, the tumor that they resected was 2.3 centimeters, which is still falling into the T2 status, right? They found certain features which was not at all high risk. That is, there was no lymphovascular invasion, no perineural invasion, margins were negative. And the sentinel lymph node biopsy that was done, they took 3 lymph nodes out. And one of the best things they found was there was no lymph node involvement at all, which means that it's still an N0 kind of a disease, right? And then they took that surgical sample and they sent it for ERPR status and they found it to be positive. And they found that it was consistent with HER2 negativity. They found that it was more, and they found the Ki-67. What is it that I want to go ahead with? I know that my patient has a T2 kind of a tumor, which is not very large. All right. I know that my patient does not have any adverse features. I also know that, my patient has moderately aggressive kind of a cancer. Okay. So based on this, what would be the next recommendation that I would want to give? All right. You guys are following till here? Am I still audible? Are you still with me? I think another 5 minutes I should be done with this. Is it okay if I take another 5 minutes?
Yes, sir.
Okay. So just 5 more minutes and we'll quickly wrap this up. All right. But if you guys are following till here, right, we did carry out a surgery for our patient. We found that the surgery that was recommended for our patient was also category 1. All right. And you can also see some of the footnotes that is being given over here at the bottom. Okay. So again, if you're going to go into footnotes, it's going to take a little bit more time. But what I'm trying to say is when you're seeing footnotes like this, do click on those links and it will definitely take you to a separate page where it's going to give you more information on what is the advantage or disadvantage of carrying out these kind of surgeries as well. All right. So this was done. Then we decided for adjuvant systemic therapy. All right. Adjuvant systemic therapy, if I want to see what is it that I want to choose for my patient. So I click on this and it takes me to this particular page. I know that my patient is a ductal carcinoma patient, invasive ductal carcinoma. I know that my patient is ERPR positive, but I know that my patient is HER2 negative. And I also know that my patient is premenopausal. All right. And if you want to see what do you mean by premenopausal, if you want the definition, you can just click on this particular footnote, which is there at the bottom, and it's going to take you to that as well. All right. And now I know that my patient is a T2 case, which has no lymph node involvement, because when we did a sentinel lymph node dissection, we found that out of the 3 lymph nodes that were dissected, none of them were positive. That's what is being shown over here, right? Which shows that it is still a N0 kind of a disease status that I have. So now looking at this entire treatment flow, right? The next option technically would be to go with this particular recommendation. So it will take me to this place, right? Where it says that it's a ductal carcinoma again. We know that the tumor is more than 0.5 centimeter. It's not less than 0.5. That is another thing that you need to take into consideration because it's not a T1A, it's a T2 kind of a tumor, which is more than 0.5. We are determining if our candidate is a good, person. I mean, is eligible person for chemotherapy. Of course, she is. We are, of course, considering also undergoing something like a RT-PCR testing or a gene testing, right? Which is also category 1, which we do recommend. But since we don't have any information, we'll consider it as it's not being done for our patient. Okay. So the next recommendation is to go ahead with adjuvant chemotherapy. Now, if you're saying adjuvant chemotherapy, then what type of adjuvant chemotherapy? You have a footnote for that, all right, which we'll look into very soon. Following the adjuvant chemotherapy, given that our patient is ERPR positive, then the best option would be to go ahead with the endocrine therapy. Which endocrine therapy? We have footnote for that as well, which we'll look into. And we can still consider if we can do an ovarian suppression or not. And this is something which is a category 1 recommendation that you get to see over here. All right. And if your patient has any high risk features, then you can also consider adjuvant ribociclib, which I feel is not really necessary. But again, it's a clinician based decision that can be taken up. But as per the entire note that we came through, this is where we realize that this is required. And once the entire chemotherapy and the adjuvant therapy is completed, we'll go ahead with breast radiation because anytime a patient undergoes lumpectomy or a breast conserving kind of a surgery, even if high risk features are not there, they do recommend undergoing breast radiation, which is something that will happen going ahead, right? So now if I say what is the kind of adjuvant therapy that I need for my patient, then you can see the particular footnote over here, all right? And if I click on that footnote, it's going to take me to this particular place. And if you remember the evidence block diagram that I showed you, it was a similar diagram with the similar regimens. And I told you which is much more relevant for your patient. And we know that our patient is HR positive, that is hormone receptor positive, but HER2 negative. So in such a case, going for something like your dose-dense AC regimen followed by paclitaxel, which can be given every 2 weeks or as weekly regimen, would be the must choice or would be the more preferred choice because we also saw in the evidence block that this is something which has more quality of evidence and more consistency in terms of evidence. We do have other options like your TC regimen as well, but it is something which is considered as a second option because it does work well in a lot of patients, yes. But in terms of the consistency and presence of evidence, I would say dose-dense AC followed by Paclitaxel has much better data, right? So this would be the option that I would go ahead with. And given that we have no information on BRCA1 and 2, and this is something which we are not really recommending at this point, then olaparib is not the option for our patient. Instead, this would be something that I would actually want to go ahead with. All right. So quickly going back to the presentation, this is exactly what we are seeing in our NCCN guideline as well. We are planning for adjuvant CT with dose-dense AC followed by paclitaxel or docetaxel, or going ahead with the TC regimen as well would be an alternate choice, but more preferably your dose-dense AC, which is usually the category 1 recommendation if you see. And following this, the next recommendation that would be given is, like I said, you want to finish your adjuvant therapy and then go ahead with breast radiation. And as per category 1 recommendation, they say that accelerated partial breast irradiation would be much better. Or you can also consider whole breast radiation with a tumor bed boost that can also be done for your patient. And once this is done, given that the patient is ERPR positive, right? And given that the patient is a premenopausal patient, the recommended choice of therapy would be to go for tamoxifen, which would be given for almost 5 years and can be considered for additional 5 years. And you can also consider doing an ovarian ablation or a suppression, which is what is more relevant for our patient. So again, quickly just going back to NCCN guidelines, if you see the notes, right? I'll start from the beginning again, the same flow that you're going to see now. You saw that our patient was T2N0M0, who was a very good candidate for receiving systemic therapy, but not pre-operative systemic therapy. We felt that it's not required because there's no adverse features. So they decided to go ahead with a less minimally invasive kind of a surgery, which is your BCS, right? After this, we did decide to go ahead with a regimen such as your AC followed by PACLI. We finished that regimen as your adjuvant therapy, which is what is recommended after the surgery. After undergoing the systemic therapy, we found that the surgical sample showed us that it is a N0 kind of a disease. So given that it's a N0 kind of a disease, this is what is being recommended. That is your whole breast radiation or a tumor bed boost along with that, right? Or like I said, if you want a category 1 recommendation, which is much better, then it's better to consider an accelerated partial breast irradiation, which is something which we would want to consider in our patient, given the low risk features that she's showing, right? So this is the recommendation, which is comparatively much more better in this case. So we have done a surgery. We have gone ahead with the adjuvant systemic therapy as well. Then we have also considered doing radiation therapy. Now, the only thing that is actually left for my patient is to consider what kind of hormonal therapy that I would want to actually go ahead with, given that patient is ERPR positive, right? So if I go ahead in this case, all right, if I say that, yes, patient is ERPR positive, patient is HER2 negative, patient is premenopausal, right? I'm just going as per the flow over here that you can just follow, all right? I know that patient has a T2 disease, but no involvement of lymph node. I click on this particular regimen and then I go ahead and I know that all these things have been actually done, right? Then the next thing that I would actually want to go ahead with is your endocrine therapy. So what would be the endocrine therapy that I would want to consider for my patient? So if you remember over here, adjuvant chemotherapy followed by endocrine therapy was a recommendation. There is a small footnote which says double F and double J. If you click on double F, which is the footnote over here, that is going to take you to options of your entire endocrine therapy, which is what we also saw in our PPT, right? Patient is premenopausal at diagnosis. Patient is recommended with tamoxifen for 5 years, which is category 1 recommendation with or without ovarian suppression. Now imagine the patient is still premenopausal even after finishing 5 years, which is unlikely, right? Because patient is already 48 years old. So if it is still premenopausal in rare conditions, you can consider tamoxifen for 5 more years, which is also what I wrote. It is considered for 5 to 10 years. Or if your patient turns postmenopausal, then it's better to switch to a drug like aromatase inhibitor, which is what we recommend for postmenopausal women, given the kind of mechanism that aromatase has. So going for a drug like anastrozole or letrozole instead of tamoxifen would be much better in a postmenopausal kind of a setting, which is also category 1. And this will also be done for the next 5 years, right? And once this is done, this is where your therapy kind of ends, right? And this is where basically you see that, your entire therapy is kind of completed for your patient. So to come to this particular treatment decision, right, we had to follow a specific kind of a sequence. I know it was very elaborative, it was very time consuming, but it does take time. And in all of this, of course, I have already gone through some of the footnotes, but given the restriction in time right now, this is something I can't go in depth about. But footnotes are something which has to be considered, especially when I was talking about the risk of the patient. How is it that we consider? And I showed you, is your patient a good candidate for preoperative therapy, or is your patient a high risk patient or a low risk patient? For all these kind of informations, it's always good to look at your footnotes. Or for example, if you say, what do you mean by premenopausal? How do you define it? Then even for such kind of things, you have footnotes which will help you to define what do you mean by premenopausal or postmenopausal women. So that's where footnotes will usually play a very important role, right? So that kind of completes the entire approach, all right? And that is why this is something which is very, uh, kind of, I would say, well established. It is having a very good flow to it. There is a very good structure to it, and it'll kind of give you a very good treatment decision or an option at the end of this, right? Which is why NCCN guideline usage is something that I highly recommend to all. And it's something which does not come immediately. Now, when I explained it to you guys, I know it's a little confusing as well. I know it is something which is not immediately stored in your head the moment I explain all these concepts. But using it multiple times will make it more easier, which is why I do encourage that you guys make a free access for yourself, register with NCCN, and I would say that you use it as much as possible for your educational purpose or maybe for making certain therapy related decisions as clinical pharmacists. And you will realize that most of the evidences that you're getting are very relevant. They're of the latest data that has been published. And this is something that, yes, can be actually used very reliably. So, yes. So, given this, I would like to end my talk. So, if you guys have any doubts, we can quickly address that as well. So, thank you so much.
Thank you, Dr. Ritesh, for such an informative session. Really have learned a lot. I think all their doubts are cleared with this session. These have been waiting for since long. What is NCCN guidelines? Where to study cancer from? How to study? What to do? What is regimen? What
Yes,
is protocol? I
yes,
think everything they would have understood this. And tailoring, I have explained yesterday, guys, how a protocol is prepared. This is all prepared from the guidelines, like how Dr. Ritesh was telling. When you choose an AC regimen, I've shown you the pre-medications, baseline test, all this. Taking the choice of treatment from NCCN guidelines, you make a protocol for the patient. For individualized patients, antiemetic medications and with reference to regimens, the antiemetic regimens change and patient preferences. So that is how you make patient specific protocols for individualized patients. I think you people have understood. If you have any doubts, you can ask and clear.
yes. Before I take any questions, this is something I don't have time to explain. I wish I could because I know we've already taken a lot of time. But I think Dr. Pravalika can share the case scenario with you. The same case scenario, which I want you to go through this NCCN guideline navigator, which is actually much more easier, and it's not very monotonous. It's not only monochromous where you see only blue lines and black font data. This is actually multicolored, and this is something which is much more easier. The same NCCN guidelines, but something when you click an option, it automatically takes you to the next thing, right? So this is something I want you guys to work on, which is a little bit more easier than looking into a guideline. And the same thing which I showed you, right? I wish I could show you because there's a complete flow of this and it's really amazing. But I think this can be one exercise which you guys can take up and you can try out in your NCCN guidelines. So you guys can just go to the NCCN navigator, and the same case, maybe you guys can use this and you'll get a better understanding how to go ahead. And you'll see the same footnotes, you'll see the same uh, notes, but you'll see that they're in different colors. You'll see that they have a much elaborative explanation sometimes and much more easier to understand. So you don't have to flip through pages. It'll automatically take you to the next thing based on what is relevant to your patient. And finally, when you finish everything, it'll say that you have reached the end of your guidelines and follow as per what is clinically significant or clinically recommended. So those kind of things you guys can look into this. It's quite unfortunate I couldn't show you this, but yes, um, yeah, I do recommend that you guys go through this navigator. It's much more easier than just looking at the PDF. It's the same thing, but much better. Yes. Any questions?
There's one question. Can methotrexate be used in breast cancer?
Can methotrexate be used in breast cancer? Of course, we have something called a CMF regimen. That is basically your cyclophosphamide, methotrexate, 5-fluorouracil. But what is the issue? Giving so many drugs, especially such antimetabolites, are going to cause a lot of toxicity, which is again a regimen that is being used. We do use it definitely, but I would say considerations of such toxic regimens when Your patient is very fit, patient is young, patient has a good performance status. We use something called as ECOG scoring, or we use something called as Karnofsky's performance status. So if a person is an ECOG 0 or 1, if the Karnofsky's performance status is very high, right, where the patient is able to carry out all the daily activities, patient is relatively very healthy, right? There we can do consider using regimens like CMF, which has methotrexate in it. So definitely, yes, regimens are there, which has methotrexate in it. I think, yeah. So it says that age also changes the treatment. Yes, it definitely does. Best example I can give you is what we just discussed about your postmenopausal and premenopausal. Postmenopausal, my option would be to go for aromatase inhibitors, right? Given the kind of peripheral suppression that it does. Whereas for premenopausal women, I would go for something like your SERDs and SERMs, which have more of a central ovarian suppression where the ovary is still active. So definitely, I would say that yes, age would definitely change the kind of treatment decision that you actually make for your patient as well. Yes. How to measure KPS? Well, you actually have a KPS scoring which is from 0 to 100%. So as and when the person's performance status reduces, you'll see that the percentage is less. Whereas if the person is able to carry out a lot of physical activities and able to be relatively fit, you'll see that the KPS score is relatively high. Or you can also see for your ECOG scoring, that is your ECOG scoring. Very commonly, you'll see that, ECOG 0, ECOG 1, ECOG 2 being written in your case sheets. If you see ECOG 3 or 4, it means that the person is relatively not that healthy, relatively having more, physical issues, or they'll be probably not able to tolerate therapies that well. So what happens in this case is you better consider a supportive care first, resolve those issues, and then consider giving some other regimen. Whereas if you have a ECOG 0, 1, 2, you can actually consider that the patient is fit enough and you can definitely go ahead with the therapy as well. Yes. Can we use rifampicin along with anti-cancer drug to treat bone cancer? Again, if you're saying osteosarcoma for bone cancer, rifampicin, I'm not 100% sure that if it's even part of the regimen, because for what I remember for osteosarcomas, we have VAC plus IE regimen. I think Dr. Pravilika would be the best person to tell you all this because she has done a fantastic job when it comes to uh, oncopharmacy and all the kind of regimens that she has looked into. But when you talk about bone cancers, I think zinc alkaloids along with your doxorubicin, cyclophosphamide, alternating with ifosfamide and etoposide, these kind of regimens I've seen. But rifampicin, again, maybe not one of the choices I would have seen when it comes to your bone cancers. Maybe if you're considering something like extrapulmonary TB, that's where you would kind of want to consider this as an option, but not for a bone cancer specifically. I think I see one more thing. Is it necessary to do liver biopsy for a patient undergoing methotrexate therapy for prolonged treatment? Well, you'll be surprised to know that liver biopsy is something that we actually don't do. And liver cancer is the only type of cancer where we don't carry out a biopsy. We have something called as a triple phase CT scan or a multiphasic CT scan, which we do specifically only for liver cancers. So you don't necessarily get to see liver biopsies. It is done only and only when you're not able to get very good confirmation by doing a multiphasic CT scan, right? Or if you're suspecting chronic liver disease, if you're suspecting cirrhotic kind of changes, and in very rare cases where you suspect that the patient is not going to have any bleeding complications after carrying out a biopsy, if the person is not on anticoagulants, if the person is not on antiplatelet therapies, right? That's when liver biopsy would be done, but it's again a very reserved kind of a procedure because it's a very sensitive technique. It has a lot of complications. Even for liver cancer, that's the only cancer where we don't carry out a biopsy, right? Whereas for other cancers, we immediately go for a biopsy. But for liver cancer, all we do is we just go for a multiphasic CT scan, and that itself gives you a very good information about the washout period from your arteries, from your blood vessels, right? From your hepatic veins and all of this, which is actually much more reliable to actually undergo proper diagnosis. So yes, not really necessary to carry out a liver biopsy if a patient is on methotrexate therapy, but yes, methotrexate is something that is hepatotoxic, and that is something that has to be considered definitely if you want to carry out a hepatic procedure. Is 6-thioguanine a drug of choice in ALL? Yes, it is. We do have more than 6-thioguanine. I think 6-mercaptopurine is also one of the most preferred choices. We do use it in block therapies. Again, that's what I've seen. But definitely, I need to read a little bit more on 6-thioguanine if you're using it in ALL, because if you see the entire regimen for ALL itself, it is quite complex. You have close to 10 to 12 plus different drugs that are actually given. And these definitely have a very good activity in terms of reducing the, what do you say? The metabolite, or not metabolite, I mean the folate kind of activity that is required for your tumor. Giving drugs like 6-thioguanine and 6-mercaptopurine can be a good choice, but I think 6-MP is something that I've commonly seen over 6-TG. Again, this is something which I think a lot of your most of your CPs can be giving you a much better answer at this point. Again, Dr. Pravalika would be a very good person to ask when it comes to all of this. I see. What are some common clinical scenarios where providers struggle to apply NCCN pathways correctly? That's a very good question. Usually, what happens is we also have our NCG guidelines, which is your National Cancer Grid. Some of the rural background physicians or physicians who come from a rural background, again, this is something which is again not necessarily supposed to be clinically true, but NCCN is something which we have seen in a lot of developed kind of places being used very commonly. Of course, there are places where NCCN is being used very commonly, even in underdeveloped places as well. Yes, there's no necessarily disadvantage or some struggle that oncologists have had, because they're very well versed in the way they use this regimen. But I think interpretation and using the latest guidelines and being actually updated on the latest guidelines is where they might struggle a bit. All right. Actually not going through things like evidence blocks, which even me in the last couple of years, I kind of got to know that, we have these evidence blocks, not being aware of that. Those are the things which will probably reduce the chances of interpreting it better, right? Struggle as of such is not very, common among oncologists because they're very good at using NCCN guidelines. Maybe as a clinical pharmacist, maybe as a student, right? As a PharmD student myself, we were never trained in looking at all these guidelines. These are things which we developed while actually using it during our, different job profiles, different work that we did. And that's where we kind of got trained on it. So maybe the kind of amount of time that we've spent on it might create a little bit of struggle since we are not very well versed with it. But with definite practice, it can be something that can be, overcome. So yes. Is professionals Are professionals also using guidelines to diagnose patients? Yes, they definitely are. Not just NCCN, we are also using it in collaboration with ASCO and ESMO, because these kind of guidelines also give you a lot of insights. But definitely NCCN is one of the most common, guidelines or pathways that we have been seeing that is being used very commonly. Yes. So does all regimen contain ESQCA evidence blocks mentioned or restricted to particular conventional or immunotherapy drugs? Of course, you have this recommendation given for all the different regimens for immunotherapies as well, but it's not specifically mentioned in your breast cancer, because again, when you talk about immunotherapies, if you would open something like lung cancer, if you open the evidence blocks for lung cancers, maybe you'll find a lot of evidence blocks for those as well, where you'll get a much better understanding. And the other thing about evidence blocks is if you see the website, it's there for only few cancers. We have guidelines for more than 60 plus cancers, but evidence blocks are hardly there for around 20 cancers, which is something that is still being developed. So of course, you might not find it for a few types of cancers, but definitely you will definitely find it for all the types of regimens. And you'll see that the variations will be there in terms of immunotherapy, your targeted therapies in terms of cost especially, right? So yes. So yes, I think this has been answered before. Like I said, Dr. Pravalika is the best person you can ask this for, right? And she's given you a very good answer. But yes, is off-label therapy is often used in oncology rather than NCCN. Like I said, off-label therapy, again, not necessarily that, it has to be a bad choice or it's not a recommended choice. Like I said, carboplatin for triple negative breast cancer, an amazing choice, but it's not a FDA labeled kind of an indication. It's an off-label indication, which is also there, given by NCCN guidelines. As per the clinical practice, using carboplatin for triple negative breast cancer patients has worked amazingly, but it's not something which is, considered as a standard application in terms of FDA approval, right? So it is still being used. I'm not saying that you cannot use it. Of course, you can use it. But again, it's a clinician-based kind of a decision that has to be taken, looking at all the evidence we have, looking at all the data we have. So yes.
Guys, as you were asking about off-label indications, when there is no other choice, no other option, when they want to try out, see, so many treatment fails. At last, they'll think they want to try out something. At that point of time, they use for off-label indications, but it depends purely on physician's choice. What
Yes.
you people are asking, and many drugs, not only in case of cancer, in many other diseases and any other diseases also, even the antibiotics also, so many things. For the immunotherapies for other things they are also using, right? They've
Yes.
now, yeah, even one drug, just not getting it. Even for this, it is not FDA approved, but it is approved in India for this NASH. They use it. I'm just not getting the drug name. I'll just tell you.
So yes, when you talk about, like Dr. Pravlika said, it's sometimes not based on the guideline, it's sometimes based on the clinical practice. If it's working really well for your patient, again, taking the genomics into consideration, for Indian triple negative breast cancer patient, platinum drugs like carboplatin have worked fantastically. Though olaparib is the drug of choice, if imagine the patient is not able to afford olaparib, if they're not able to access olaparib, carboplatin is easily accessible and very commonly available. So those kind of regimens, though it's not FDA approved, it's an off-label indication, it can be something that is, easily considered and does work well in your patient. So definitely you can consider that, right? And I think, yeah, there's one more question where somebody is
Yes,
asking me this.
the drug is saraglitazar, guys. It is not FDA approved, but it is approved in India with very fewer side effects. For
Yes,
NASH, it is used. So everything need not be FDA approved, And also sometimes it depends on, epidemic. Some countries, US, some regimens are very nicely approved, like how we were talking about dosing of Capox. Capecitabine 1000 mg per meter square is used elsewhere, everywhere, but 850 only in India. It also depends upon the status. Some people tolerate, and Indian population do not tolerate. So in many things, the dose also it may not be approved. Sometimes you will have to give a higher dose to fewer patients. Sometimes you will have to reduce the dose for fewer patients. Not only drugs, dose also you can exceed and you can decrease also. That is for capping of carboplatin. Some people they give more dose, but still they don't see adverse effects. For some people, at lower doses also you will see adverse effects. It's all pharmacokinetics, how people are tolerating in most of the cases when you see.
yes, I think we can quickly wrap up. I think we just have two more questions. I'll just quickly address that as well. Somebody's asked me if regimens are considering comorbidities as well. You might not have the information put up over there, but if you say for a simple comorbidity like hypertension, and if you want to use a drug like bevacizumab, which is an anti-VEGF inhibitor, right? There are possibilities that these anti-VEGF inhibitors can further elevate your blood pressure, and considering those kind of options, right? You'll have to be a little careful because hypertension can be worsened by using such medication. So you would want to look for other therapies which are more better, right? So it might not be directly given in the regimen or in the guideline directly, but having a clinical knowledge of this as a oncopharmacist or as a student would definitely help you make a better decision, right? That's what I'm saying. Like NCCN is not something, like I mentioned, it's not going to impact your decision. It's not going, I mean, it is not going to give you a final decision, or it's not going to tell you what has to be taken. It's just going to guide you as per your understanding what you want to choose. So it's not going to tell you that you have to choose this. It's just going to tell you, it's good if you choose this and what is the advantage of choosing this. So that's the thing. So yes. Any other questions? Somebody's asked me if someone's bone marrow is transferred, how does a donor live without bone marrow? Again, it is not that you're completely, you know, donating your bone marrow, it's of course you're donating stem cells, which is of course a very safe procedure, and it is something which is highly recommended, and it is not something that's going to adversely affect the patient as well, right? Of course, there are certain contraindications to carry out bone marrow transplantation, but definitely it's something which is not a highly invasive kind of a issue, because you're just collecting the stem cells, you're preserving them, then you're donating them. So it does not really require a very extremely invasive kind of an issue which will cause problems to the patient. So there's nothing to do in terms of life-threatening problems that will come to the donor. So there's nothing to worry in such cases. Yes. Yeah, I think we're good to go.
Thank you
Yes,
so much,
Dr.
sir,
Ritesh.
Thank you,
for that
guys.
insightful session. That brings us to the conclusion of our session for day 4. A sincere thank you to our distinguished speaker for their expertise and to the audience for your active participation. We hope you found today's discussion enriching and valuable for your professional practice. We look forward to meeting you again in the upcoming sessions of the Conclave. Good night and thank you for being with us today. Thank you so much.